marketing and media strategist for Pezzy Publishing. Thank you so much for joining this special training on postpartum anxiety, rage, and burnout. I'm pleased to introduce today's experts, Caitlin Slavins and Chelsea Bodie, also known as the Mama Psychologists. Caitlin is a registered psychologist, EMDR therapist, and certified TheraPlay professional. She has additional training in attachment parenting, play therapy, child-adolescent mental health, and trauma modalities. Caitlin is a registered psychologist and certified perinatal mental health professional with training in perinatal mood disorders, birth trauma, perinatal grief and loss, and infertility. She also has training in play therapy and child-adolescent mental health. They are also both moms to two little ones. Together, Chelsea and Caitlin run the popular Mama Psychologists Instagram page, offering support to 460,000 parents in their online community. They are the authors of Not Your Mother's Postpartum Book, which released just this past January. Now, before we get started, I'd like to go over just a couple of housekeeping items. We have over 12,000 people registered for this event today, and I want to share a couple of ways for everyone to maximize their time. The first item is the Q&A function. This will appear on your Zoom toolbar. We currently have this turned off, but we'll turn it on in a few minutes. The Q&A will be for your content related questions only. And due to the volume of people joining, before submitting a question, please look to see if it has already been submitted. If it has, or if you have a question that you see that you want answered, click the thumbs up button underneath it to kind of bump it up in the queue. Make sure to keep an eye on the chat for important announcements from the Pezzy staff. And if you have any event-related, CE, or technical questions, please go to the FAQ tab in your event portal, and the answer can be found there. Thank you for helping us make this event successful. And with that, I'll turn it over to Caitlin and Chelsea.
Hello, everybody. We are so excited to be here. We are so glad that everybody was able to take time out of your day. We know everybody's so busy. So we appreciate you guys spending the afternoon with us and allowing us to share some of our knowledge, some of our experience, and some of our tried and tested strategies with you guys. So of course, any questions, make sure to drop them. We will try to get to as many as possible. And yeah, we're just so excited to spend this time with you guys. So we will get started. Okay, so my name's Caitlin, one half of Mama Psychologist, and in our introduction, she was able to share a little bit about who I am and what's important to me. So I have two littles, one boy that's 6 years old and one girl that's 3, almost turning 4, that is very spicy and keeps me on my toes a lot of the time. So we really got started in postpartum mental health after the birth of our kiddos. So we're both located in Lethbridge, Alberta, Canada. We're best friends. We've been friends for a decade, over a decade now. And we really reconnected when we both went through significant struggles in the postpartum period. So for myself, struggling with postpartum anxiety with my firstborn and some intense breastfeeding and formula feeding struggles with my first, to a little bit of postpartum depression with my second. I really kind of experienced it all in terms of my own postpartum experience and so on. So that is really what led me to be interested in postpartum mental health.
Yes. Well, hi everyone. I'm Chelsea. So Caitlin and I's stories from an education and work experience background are very, very similar. So I won't reintroduce that side of everything, but like Caitlin, I have a little boy and a little girl. And what really, again, connected us on my end was my little boy was born at 27 weeks. And so we were in the hospital for about 3 months out of our hometown. And so I really struggled going through the NICU and feeling that isolation and that loneliness. And I felt really isolated and I didn't really understand what a traumatic birth was, what the resources were for it, and found that I was definitely not alone in that struggle. And so when I had the opportunity to get further training on top of the family and child and adolescent mental health, I really dove deep into birth trauma and the perinatal aspect of parenthood and motherhood. And that kind of led me, I guess, back to Caitlin.
Back to connecting. And then that is really where Mama Psychologist was born. And we intended it for it to be some education for our local community, but then also seeing the gap of education about things that extended beyond postpartum depression, like postpartum anxiety, like birth trauma. We really just saw this gap that other moms were experiencing. So, and that led us to Mama Psychologist and almost 500,000 followers later, and an amazing community and book. So again, thank you guys for being here. That's just a little snapshot of who we are and what led us to be here in front of you guys today. Okay, so we're going to dive into it. So what is anxiety? So anxiety can also be referred to, as feeling nervous, feeling worried. It is often a catch-all term for just feeling, tense and feeling those physical changes. So it can also include reoccurring intrusive thoughts, concerns, areas of concern, and avoidance of situations. So it can often be very future-oriented or past-oriented. So when we look at anxiety versus fear, we see it's similar, but anxiety is more of a long-term, future-focused response, whereas that fear is more in the short term, or, oh my gosh, there's a dog barking, coming at my kids. That is a response to a direct threat. So postpartum anxiety is definitely getting talked about a lot more. I know when I first had my little guy 6 years ago, even though I was a mental health professional, I knew about postpartum depression, I knew about postpartum psychosis, but I didn't know about postpartum anxiety. And coming from a past where I had struggled with anxiety pretty significantly, of course, I would be more at a higher risk to have that. But I found myself really like, oh my gosh, I am really, really anxious. I don't know why. Is this normal? Is this not normal? Like, should I be feeling this much anxiety considering okay, I have a new baby. Maybe I should be this worried. I just really didn't know and wasn't necessarily properly screened for that either. So the official definition of postpartum anxiety is any anxiety that is diagnosed during the perinatal period. So that is pregnancy and postpartum up to a year. So when we look from a stats point of view, about 17 to 20% of postpartum women are diagnosed with anxiety. So we've also done 4 postpartum virtual groups during the pandemic. During May 2020 to September 2021. So out of was probably 60 moms that we worked with, about 80% of those moms struggled with postpartum anxiety. Keeping in mind, this was the height of the pandemic, and that number would have been exacerbated because of all of the things going on during that time. So another thing that may impact this number is the support available. Does mom have people in her life that are able to help her? Does her family live far away? Is there a good relationship with her family or her friends? relationship with partner? Is that relationship stable, or is it rocky? History of anxiety, if there's been any birth trauma, premature birth, or if there has been a hospital stay, a NICU stay. Okay, so this is a post that we've shared that we get a lot of positive feedback. So often when moms say that, like, okay, I'm struggling, sometimes that the response from others can be like, oh, well, I really struggled, or I had it like so much harder than you did, right? Or comparing their struggle to, oh, well, Sarah from high school had a hospital stay of a couple months and she doesn't have a partner, things like that. So we really want to drive home that, you know what, when moms say that they're struggling, they're asking to be supported and validated in that, not necessarily dismissed or told, like, you know what, your struggle isn't really that bad. So another study that was done, a Canadian study, I think it was 2021, showed that depression, postpartum depression and anxiety have increased substantially since 2019. And mind you, this is pandemic numbers too, but just showing like, holy man, like moms were disproportionately affected during the pandemic. Okay, so some warning signs that you can explore if you're thinking this mom has postpartum anxiety. So are they able to sleep? Are they able to rest when they do have that opportunity? And I know, of course, if you have a new baby, it's really hard, but when, you know what, baby is sleeping, are they able to sleep? Are they able to have some rest? Or are they really having struggles with that? Emotions just being really, really difficult to manage. And some of those old maybe coping strategies aren't necessarily working as well. Easily overwhelmed, changes in appetite. So maybe eating a lot or not eating at all. So intrusive thoughts, we'll talk about that a little bit later. Racing thoughts that just continue to bombard them, kind of that worst case scenario, difficulty concentrating, and then fears related to baby or oneself or partner. And then, of course, some of those physical symptoms. So the headaches, the feeling nauseous, stomach pain, feeling tense, shaking, sweating, like some of those panic attacks as well are all warning signs that we want to be on the lookout for. Okay. So again, this is something that I also struggled with. Okay, is this anxiety, postpartum anxiety, or is this, okay, you're a new mom, it's normal to be worried? So sometimes it can be a little bit hard to distinguish if it's that normal worry or anxiety. So we want to look at how much of this is impacting their daily life. Is it, you know what, it's something that comes up, but then, okay, yeah, that's a worry, but I'm able to go on with the rest of my day. Or are they maybe not leaving the house because they're having fears of getting into an accident or not being able to cope with the babies crying out in public? And also, how distressing is it to them as well? So we want to look at how much does it impact their day-to-day life, and then also how distressing it is to them.
So when looking at some formalized assessments, it is quite limited in terms of what we have access to and what we can use in the screening process. So the things that Caitlin was just going through, a lot of times this is done through conversation and through, hearing the person you're working with and hearing some things that they're sharing with you. However, if assessments are within your scope of practice, there are some that you can consider utilizing, and that can help you guide that case conceptualization, that can guide treatment planning, that can guide where are they at, and kind of understanding their symptoms a little bit further. So typically one of the most common ones is the Edinburgh postnatal depression scale, EPDS. So this is the one, if you've had a baby or you've done the screening, it's the one you typically get at your 6-week follow-up with your family doctor or your OBGYN. It's the one that they just give you and you check off the circles. I think it's like 13 questions, and then they score it and they're like, yep, you reached the cutoff. No, you don't. And that's kind of sometimes the end of the conversation, unfortunately. So while that is typically screening for depression, it can be utilized as a tool to guide conversation. And what we mean by that is you can see what answers that they provided on the EPDS and also say, okay, what else is going on? Can we talk about this? You know, you mentioned that you're having trouble sleeping. What does that look like, right? So we really encouraged, well, the cutoffs are great. It's really more important to actually utilize it as a conversation tool with your client and exploring it a little bit further and discovering what's going on, because sometimes it's also really hard for moms to share what they're experiencing and what they're going through. So just another concrete way to kind of go through that. One of the more newer scales is the postpartum specific anxiety scale, the PSAS. And so this one can be utilized more specifically, again, for the anxiety piece. So the questions are more tailored to the anxiety, the intrusive thoughts. Again, we'll go dive deeper into that in a little bit here. And more generalized scale that you can use is the Beck's anxiety inventory. So while not specifically for the postpartum period, you can kind of see where their thoughts are lying, you know, what's going on for them and whereabouts their anxiety levels are at, and utilize that again as a conversation piece. We never just want to give these standardized assessments and not have that conversation about it to understand a little bit further what your client is going through.
Yes. And just from a personal standpoint, that happened to me. And it's like, okay, here's the questionnaire. And that was it. And I gave it back, and there really was no conversation. If there would have been more conversation, that likely would have increased my comfort level. Right? And we always want to be looking at that. Okay, is my client feeling comfortable? Are they feeling safe in sharing some of these things too?
Mm-hmm. It's also a good opportunity, is sometimes maybe they weren't 100% truthful on those skills, right? They're limited. So it's kind of easy to just circle, oh, I think this is what my health provider is wanting me to share, or, you know, this sounds better. You know, I am feeling this a lot, but I'm going to put sometimes because that feels less intimidating for me. And so again, that's where that conversation just becomes so important to really understand, like, okay, are you feeling like this is accurate to where you're at? And how can we further expand on this? All right, so one thing that's really important to also have in your toolbox is additional supports that are within your medical community. So of course, depending on what your profession is, we all have our own scope of practice and they don't often overlap, right? That's why we have resources. That's why we have teams and support. And so being able to know what and who is in your community can be really beneficial, because we want to be able to provide that and connect those pieces when we're in those appointments with our clients. We want to be able to share, like, do you have a medical physician? I know in our area right now, we have an OBGYN shortage. And so it's really hard. Half of our city doesn't have a family doctor. And so being aware of what supports they have already in their life, or maybe what they're lacking of, can be part of that conversation and part of understanding, okay, is that contributing to that anxiety that you're having because you're not sure, you know, if something's wrong, if you can go to a medical doctor or not. And so having a quick Google search, asking around in your community to try to understand who is out there can be super beneficial, and also allows you to also know when you're out of your scope of practice and when it feels like, okay, I can help this far, but now I need to refer on to somebody else. So again, we're looking at medical physicians, psychiatrists, lactation consultants, postpartum doulas, or if your client is still pregnant, a doula, a midwife, public health nurse, right? Mommy support groups and connection. It can also be super beneficial to look at what are online resources that you feel are reputable and would trust sharing for your client as well, because sometimes as moms, it's limited, right? If they have really bad anxiety and they can't get to that therapy appointment, they can't get out of the house, you know, they feel really isolated and alone, and then they're feeling even more limited at what they can access. I know I have clients come in all the time and they're like, I took months for me to get here because I just couldn't make that appointment, or I felt intimidated to call, or my schedule just didn't work, or childcare was a barrier, right? There's so many different factors that we might not be aware of, or we might not even know they're looking for support. So having that there, being able to have that conversation when you're doing this assessment and screening and understanding, okay, where's my client at? What supports do they have? And having these in the back of your mind, are there any additional resources that we can really share and provide for our client? And it can be a really nice way to just explore, again, where they're at and where they're coming from. All right, so brain changes in parenthood. So we often will hear clients come in and say, I was never anxious before, or this was managed before I had kids and I felt like I was doing well, I was on medication, everything felt like it was just rolling along and I didn't feel like I was really impacted by my anxiety anymore. And they go, why now? Why in motherhood? Why in parenthood? Well, it's really important to consider all of the other factors that are going on. So we're looking at neurological, biological, psychosocial, and physical changes that are all occurring at once. And it can be a lot, and it can feel unconsciously or consciously overwhelming to the client, right? There's a lot that's happening and a lot of structural changes. And so with this, their underlying well-being is going to be impacted. So it's not uncommon for you to see this anxiety arise in that perinatal period because of everything that is going on, right? Again, structural brain changes, hormone changes, the sleep deprivation that comes with being pregnant and uncomfortable, or if they're anxious, right? If they've had difficulty trying to conceive, they've had pregnancy loss, they've had medical scares, right? There's so many factors that can just layer upon layer that are going to add to how your client is feeling and add to that anxiety. When we again, going back to the pandemic, when we had clients doing telehealth at that time, it was really this big unknown, and that unknown and lack of control was creating this sense of anxiety. And of course, there's a natural stress that comes with parenting, right? There's a natural increase in workload. There's a natural loss of control, right? Some of these things are what comes with parenthood. And if you're struggling with anxiety, or there's that risk of having anxiety, then that is heightened automatically already. And so when we're looking at these risk factors and these things that could impact if somebody is exhibiting anxiety or not, it's really important to look at all of these different facets so we can understand how it's impacting our client. And sometimes this knowledge can be really impactful for them and really powerful, right? Knowing that there's neurological changes and hormonal changes going on and having conversations around that, it can feel a little bit empowering to the client because they feel like they have a better understanding of what's going on and they don't feel as lost in it, which can be really important and really powerful for them. So they feel more confident in understanding it.
Absolutely.
So let's break down some common sources of anxiety. So we kind of broke it down into categories just to think about it a little bit differently. So when we're looking at like that perinatal postpartum anxiety, these are really three common themes of where anxiety arrives. So health-related concerns, so often related to baby or self as well. Thoughts of SIDS is a really big one, and fear of exposing baby to harmful germs, right? What if baby gets sick? You hear it all the time. I don't want to give my baby to my relative to hold because I'm so afraid that they're going to be sick or they're going to catch something and then we'll be in the hospital, or even worse, what if the baby died, right? There could be a long spiral of thoughts that come with that and with health related stuff. Injury is another really big one that will pop up. So thoughts of dropping baby, thoughts of hurting baby, thoughts of what if I slip down the stairs and I fall baby out. We've even heard, what if baby falls out the window, right? Sometimes it can feel really rational and sometimes it can feel really irrational or not really make sense, but just something causing injury to the baby. Physical and sexual is another really common one. This one is often the hardest for people to talk about and the hardest for a client to share because it can feel really shame-ridden and guilt-ridden that these thoughts are coming up. So this is often unwanted or disturbing sexual imagery that can come up for clients related to their baby from themselves or from other people around them. Common sources of parental anxiety. So this is ones that can pop up outside of the perinatal period. I know we always have the debate, what is the perinatal period? Again, textbook says it's a year. We would argue it's longer than that. So we'll just call this one parental anxiety. But some really common ones that will come up in this one is the medical intervention that is needed throughout pregnancy, birth, and thereafter. So if there was difficulties conceiving, if there was medical concerns for mom during pregnancy, and if there's, of course, a NICU stay, disease or illness, or previous experiences with that, right? If it's a subsequent pregnancy and their first baby was a NICU, sometimes that can heighten the anxiety of, I don't want to relive that experience again. Of course, their pregnancy and birth experience, so birth trauma. We would argue birth is traumatic physically at the very minimum, no matter what, no matter how baby arrives in the world, and of course, that emotional impact of it as well. And if you have a complicated or high risk pregnancy, so if there's something, twins, for example, if your client has 2 uteri, right? There's so many different things that can contribute to a high risk pregnancy. And so if that is a factor as well, there's a natural heightened anxiety that will come with that. And of course, pregnancy loss and infertility. So if your client has had a history of pregnancy loss, if they've lost a child, if they've needed significant interventions to get pregnant, then that can all heighten anxiety as well. Yeah, that's good. Again, these are similar to ones we discussed in the perinatal period, but health, again, of the child, health of yourself, becoming ill that you can't take care of your child. Sometimes we call this a little bit of like existential anxiety can come up. So, what happens to my children if I die? What happens? Who's going to take care of them? Will they take care of them as good as I can? So different things like that often tie into that health related anxiety. Thoughts of, again, the child becoming ill and self. So when we look at injury, this could be, again, thoughts of if it's a younger child falling, being injured, mom or dad dropping baby, right? Anything like that, a relative, it could be falling off a bike, falling off the playground, right? There's so many different ways. I know my son is really good at getting injured. So there's so many ways that this can happen, right? And so many different facets that can impact somebody. And so when you have all this material, essentially, of injury, it can feel really overwhelming. And there often are a lot of planning and trying to figure out A, B, and C, D scenario that can happen when you go somewhere that heightens that anxiety. And again, that's physical and sexual violence. So kidnapping, sexual harm, or fears of a violent act towards a child. And the last 3, we've gone over a lot. So the last 3 is work-life stressors. So this is more from a parental perspective. So the impact of what working outside the home, working inside the home, working from home, right? There's so many different areas that we hear from moms all the time. It's hard to find that balance. I feel like I'm being torn in so many directions. If I'm at work, I'm thinking about my child. If I'm with my child, I'm thinking about work. So there's a lot of pressures that can come with that. And of course, financial concerns related to if I work, if I stay at home, what does this look like for my family? And sometimes the options are limited, and that feeling of being stuck can often come with the work-life stressors. Sensory stimulation is also a big one. So sensory overwhelm, feeling like your sensory system is overloaded, of course, feeling touched out, crying, screaming, all of those things can feel like a lot, even like lights, sounds in your house, combination of the factors, right? Thinking about the 5 senses essentially, and how your nervous system can become overwhelmed with that. And we'll talk a little bit more about that a little bit later. And of course, the trait of being a highly sensitive person. So when we talk about being a highly sensitive person, what we're looking at is the spectrum of handling sensory stimulation. Some people are better able to handle that stimulation. They have a bigger capacity. Noise doesn't really bother them. Touch doesn't really bother them. They can just handle their environments a little bit differently. When being a highly sensitive person, on the flip side, you have more limited capacity. And so your sensory system often gets overwhelmed more quickly than it does if you're someone on the other end of the spectrum. And of course, past trauma. So any past experiences, even non-traumatic childhood experiences, traumatic events, all of these factors can impact how someone obviously views the world, feels about their environment, feels about their safety, and can impact that anxiety piece.
Okay, so with all of this being said, what are some common behavioral outcomes that we do see? So often when we're talking to moms, we're seeing that difficulty separating from their child, not wanting, I don't know if you're good enough to watch my child. I don't know if you're going to keep eyes on them all the time. So always researching, looking everything up. And with that research, we really find that there can be a spiral of Googling something and then continuing to Google because they're trying to find that answer that makes them, okay, feel safe, feel good, and really going down that loop. And we know Google can be a very, very vicious spiral. So avoidance behavior. So maybe avoiding like going out because, okay, I don't want to get into an accident. Or I've even had moms that avoid like taking their child for a walk because it's like, oh my gosh, what if we get hit by a car, or sliding downstairs on their bums because there is that thought of like, oh my gosh, I'm gonna drop my baby. And again, like trying to control and plan and avoid every single aspect and things that are just out of one's control. And of course, difficulty regulating emotions. So lots of ups, lots of downs. And there also can be more explosions, more conflict within certain relationships. Okay, so let's talk about intrusive thought. Again, this is one that is so common. Research has shown that 70 to 100% of new moms experience intrusive thoughts. So these thoughts can be related to accidental harm, where you're walking down the stairs and you fall and you trip with your child, or it can be related to intentional harm, which is commonly more distressing for the parents, where it's like, I just had the thought of like throwing my baby off the balcony or throwing them against a wall. So a couple of the different categories are, again, accident, injury, that they become very, very sick and we're not able to care for them, or violence from self or from partners or from others. So sometimes they can be thoughts, or sometimes it can be images, just these little flashes, these little scenes that play out in your mind. So it's important to know that two people can react very, very differently to intrusive thoughts. And it's not necessarily a problem until they start taking on a life of their own, and until they start this very vicious cycle of anxiety, where the mom is questioning their ability to cope, to care for their child, and questioning like, why am I having these thoughts, and why can't I control them? So as a clinician, it is so important to talk about how common these intrusive thoughts are. And again, being a mom who experienced intrusive thoughts and yet nobody talked about them, I'm like, am I a bad mom? Is there something wrong with me? Am I like crazy? Having some of those really, really distressing thoughts come to my mind because I just never experienced them, and I wasn't told about them, and none of like friends or family ever really talked about intrusive thoughts, right? Because it can feel uncomfortable to talk about those thoughts and to think about those things. So it's often we get a sigh of relief when we talk about intrusive thoughts to moms, and they're like, oh my gosh, I thought it was just me. I thought I was the only one that was experiencing these thoughts. And it's no, these are very common. And then some people say, well, what about the people that do harm their kids? Because we see the news and we see, those terrible stories. So if the intrusive thought is distressing to the individuals, that is a protective factor. If it feels super incongruent with who you are, that's a protective factor. If these thoughts come and it doesn't bother you, then that is what we would consider, you know, a medical emergency. That's when we need to get a higher level of care and more help. But if these thoughts are distressing to that person, right, that's what we want to see. Okay, so again, why aren't they talked about? Lots of us have, you know what, had moms or sisters or friends that have had children, but then yet nobody really talks about it. And I know with social media and some accounts like ours, we're talking about it because we wanted to be known that these thoughts happen, and you know what, you aren't a bad mom for having these thoughts. So why the heck do they happen? So when we think about our brain changes in motherhood, we're wired to look for that danger. We are in charge of something that is so important and so precious to us. Our brains will constantly be scanning for danger, and sometimes that danger will be, oh, that balcony, so I'm gonna have an intrusive thought about that balcony. Or sometimes it's like, oh, I have the ability to cause danger, so you have that intrusive thought about yourself. Okay, so with screening tools, we want to have that conversation. Are these concerning to your client or your patient? What other red flags are coming up? Okay, so again, this is a couple slides that we did on our Mama Psychologist page that had a lot of feedback, a lot of moms saying like, oh my gosh, yes, this is me. Right. So again, knowing that they can feel scary, they can lead to intense feelings of shame and guilt. They're often like unconscious. We don't want these thoughts to come. They just come. So they can be constant, or they can just kind of like pop up every once in a while. Okay? And they can happen even if you don't have postpartum anxiety or postpartum depression or a perinatal mood disorder. They can still occur. And then again, some examples that don't feel great, right? So it's like, what if they drown? What if my baby doesn't wake up? Right? What if I throw my baby when I'm angry? Right? What if I like drop the knife and cut my baby or do it on purpose? So again, it's also important to have those frank discussions, because sometimes people will like tiptoe around those words, but it's like, yes, these are thoughts, and these thoughts do happen, but it doesn't mean that you want it to happen or that you're a bad mom because of it. Okay, so why does it get so bad in motherhood? Why do these intrusive thoughts seem so hard to manage? So again, sleep deprivation, anxiety, stress, just not having your typical maybe routine coping strategies, support can all contribute to a bit of the perfect storm. And then people also, they can get into a pattern of avoiding things. So, oh, I'm not going to drive. I'm not going to walk down the stairs. Of avoiding these triggers to make themselves feel safe, right? Which in turn is really reinforcing that anxiety and that distortion that, oh, I'm not safe. Okay, so giving that power over to the anxiety and intrusive thoughts can just continue and often increase that cycle. Okay, so how do we work through these intrusive thoughts? So we want to reframe the intrusive thought as just a thought. I am having the thought that I'm going to drop my baby. I'm having the thought that I'm going to throw my baby over the balcony. When we reframe this as a thought, it helps create separation between the person and the thought, and it activates their prefrontal cortex, their thinking brain, and it helps get them back into their logical mind. So again, working with, okay, I'm having the thought that X, Y, and Z. Having that script that your client can utilize will help them create that space. Okay. And of course, the brain doesn't like to think in negatives. So we want to avoid telling our clients, just don't think about it. Don't think about it. Because it's like, oh my gosh, that's all I'm thinking about. And that can often make the intrusive thoughts stronger. Okay, so we also want to continue to monitor, what are these strategies working? Are they like, what, that was helpful. I'm able to kind of get a grasp on that once I have some education, once I have some strategies, or are they just, I'm still spiraling. So if not, then these intrusive thoughts may have the root in trauma that the client may need to work through. So also the end goal, we're not going to get rid of them. We don't necessarily want to get rid of them, but to realize that they don't mean anything. Okay.
All right, so now we're going to dive into some cognitive distortions. So these can fall under a lot of different struggles, but they're very common in anxiety, right? Cognitive distortions are thinking errors or patterns that we can find ourselves in, and they're extremely common and they happen unconsciously without us realizing. So these are just some things to look out for. Again, these can be conversation pieces. These can be things that are fueling the anxiety for your client, heightening those feelings of distress, and impacting how they're viewing themselves in general. So it's really important to try to kind of catch some of these cognitive distortions when working with your clients. All right, so should statements. So when you're listening for should statements, you'll often hear things like, I should do this, X, Y, Z. I have to do this to feel like a good enough person. If I do X, Y, Z, I'm a good enough person, or that shows I'm doing enough. So in motherhood, this will be like, if I make sure the house is clean and my baby's well taken care of, we do the crafts, we do the activities, we have screen time, obviously we're not going to do with our baby, but I mean, if we're doing, having an older child, right? They're like, I don't want to do screen time. That's not for me. I've read all the things. I feel like if I give my child screen time, I'm failing, right? So you're going to hear all of these things. These are negative things that they are either not doing enough of, or if they're doing these positive things, then that is contributing to their self-worth. So that's what kind of we're trying to hear for in should statements. Black and white thinking. So this one is extremely common as well. You're going to hear these really black and white statements. You're not going to hear a lot of flexibility in the way they think, in the way they do things. They also can sometimes believe that others should be doing this way. So when, again, looking at parenting, this can sometimes come up as gatekeeping, right? If mom is thinking, okay, this bath time needs to be done in this order, and the hair needs to be washed, and then the body, and then they have playtime in the bath, and then they have to get out, right? And then if their partner goes in to do bath time and they don't do that order, it's like, oh, bath time, you can't do bath time anymore. This isn't how we do bath time. And so sometimes it can contribute to feeling like we can't get that support because we feel like things aren't done right. And then we're feeling like we're overwhelmed because we're not being able to get the support that we need, right? So it's feeling more rigid and overall having difficulty with flexibility. So think of it as there's no real gray area for this person. That's kind of what you'd be looking for. Mind reading. So with mind reading statements, you'll often notice that clients are assuming that people in their life or people around them are often thinking negatively to you or viewing them in a negative light, blaming them for something. And there's often little to no evidence that this is true. Like, for example, a client may come into the session and be like, I didn't do what you said. I didn't do what I said I was going to do. So I'm assuming you're going to be disappointed in me, right? And it's like, okay, where's that feeling coming from, right? That's nothing that I've said. So that's often like an internal process that's happening. So it's something that you really want to pay attention to, because if they're viewing that the people in their support system or in their life are viewing them negatively, it can heighten that anxiety, but it can also be a barrier in sharing what they're experiencing or what they're going through, because they might feel that shame and guilt and stigma underneath that, right? Like, oh, I shouldn't be feeling anxiety and you're going to judge me for being anxious and think that I'm a bad mom. Or if I have these intrusive thoughts and I share that with you, you're going to assume that I'm not a good mom and that I want to harm my baby. So it's kind of trying to find, okay, are they assuming that their support network is feeling negatively about them? Catastrophizing. So this is sometimes labeled as an overreaction, but this can also look like basically clients feel like they're making things feel disproportionately large for what they're experiencing. So for example, you'll see like if they get something that makes them late, for example, they're like, oh, I couldn't find my car keys and I was late getting to this appointment today. And they feel like to them, it truly feels like it's the end of the world. Like it's the worst thing that's happened to them that day. And it can feel really overwhelming, really big. Every problem can feel really big, and that can contribute to that feeling of overwhelm. So when they're feeling anxious and overwhelmed, they don't know really how to get through that, right? And they're kind of planning for everything to go negatively and to be really big. So fortune telling, this is similar to mind reading. However, this is more based on situations, events, and experiences. So the client will often tell you that things are going to turn out badly. If they go to the mommy group, bad things are going to happen, or they're not going to be supported. They're not going to have fun. Other moms are going to judge them, right? They're already planning for the event that they're going to turn out badly or impact them negatively. Again, this can limit the support. This can limit reaching out. And we really want to kind of find out, okay, is this a barrier for you, this fortune telling, in accessing different things, in doing things you want to do, in creating a sense of community, if that's something that you're looking for, right? So again, can heighten the anxiety that way. Mental filters. So this you'll often notice is someone has a lot of difficulty seeing the positive or even seeing neutral situations, right? Just seeing something as it is what it is, and that's what happened to me today. There's often a big sense of hopelessness that comes with the negative mental filter, and they often will primarily see the negatives that happen in a situation. So you'll often hear them highlight a lot of buts is kind of a way to kind of look at it. So they'll hear, this and this happened, but I still got anxious, or I still felt like I handled it wrong, or I should have done this better, right? So you're kind of listening for that. What aspects of situations are they seeing? Can they see any positives, or are they primarily seeing that negative side of things? Personalization. So this is often, again, kind of assuming we have more control over things we don't actually have control over. So we're assuming that we're influencing or causing influence to other people. And so what can happen is, if somebody doesn't get a text message, for example, or somebody doesn't check in on them, they take that really deeply. They think, okay, there's a particular reason that this person is excluding me. There's not that kind of sense of, oh, maybe they just forgot, or maybe they were busy, or maybe they had their own stuff going on. It's really an internal thing that they see, like, I did something wrong, and that's causing this person to not want to engage with me, talk to me, reach out to me, for example. Emotional reasoning. So this is assuming that all emotions that are experienced are the truth and an indication of reality of that person. So kind of wordy. What do we mean by that? So this person may have that feeling of like, oh, I just did something really dumb. I can't believe I did that. I feel so dumb. Therefore, I am dumb. Like there's no separation of having the feeling and what the person is. So there can be a lot of negative emotions that build up, and the view of self becomes very negative with emotional reasoning, especially if they're feeling quite anxious, because often those feelings are negative, right? So it's kind of reinforcing that negative belief of self. So labeling. So this again is classifying their character. So I am a failure. I am a bad mom. I am doing this because I am just not a good person, right? There a lot of labeling will come out is like I am statements. And you can hear that a lot. And again, it feeds into that negative core beliefs of self. So these thinking areas what does it mean when your client has them and what do you do? So again, these are referred to as cognitive distortions, and they often create that sense of anxiety because they're feeding that negative beliefs of self, they're feeding the negative view of the world, and they're really reinforcing often shame and guilt for the client. So it's important to recognize these thinking errors, because when we challenge them, understand them, we can really understand how the client's viewing themselves and viewing the world. And that can really make an impact on that anxiety, right? If we can kind of get a handle on some of these cognitive distortions, which we'll dive into a little bit later, and shift into some of that positive thinking or even neutral thinking, if positive is really overwhelming at that time, then it can be really beneficial for the anxiety itself. So challenging the negative self-talk. So one, we want to acknowledge it, right? Again, I'm having a thought, I'm having a tough time, I'm having this belief about myself. Sometimes it's even, using the actual language of the cognitive distortion. I am personalizing this right now. Really, we want to acknowledge it and label it. We then want the client to validate the emotion, like, it's okay. It's okay to make mistakes. It's okay to have these feelings. These feelings aren't wrong to have. And then challenge them to look for the evidence. So what evidence do they have that these cognitive distortions are true? This step is often very difficult because the evidence they're looking for is going to reinforce that cognitive distortion or belief that they have. So that's where that work with the client can be really helpful, because we want to help them look for other evidence or other things that aren't true. So in motherhood, for example, what's something you did that was awesome? Like, you did this for your child, you did this for your baby, you did this for your pregnancy. What is something that happened within that time period that we can use and try to see it in a more positive light? Another really great step in this is evaluating the thought. So really trying to break it down. Is this thought that I'm having, is it helpful or harmful to me? Like, what is this doing for me and to me? And really reflecting on that can give them a chance to reflect on it and understand it. Then, of course, thinking of that alternative perspective. So, how would you talk to if this was a friend? How would you talk to this if it was your sister, your mom, somebody in their life that feels really important? Exploring how they're breaking this down, sharing it with them, and seeing, are there bits and pieces that we can incorporate for yourself? And one of our favorite mantras is, your thought is just a thought. It does not define you. And having them utilize that can be really beneficial.
Okay, so that leads us to our discussion. So we are going to break off into groups, and you guys are going to chat about what you find most challenging about working with a client who's experiencing intrusive thoughts. And then also, what have you found to be most effective when working with a client with intrusive thoughts? Okay, so we are going to break off. We're also going to have to switch the presentation slides. I just realized the one that you guys were looking at was not the most updated one. So there's some spelling. So we apologize for a few spelling errors, but we accidentally updated the old one, but it'll be fun. Okay, so off into groups and we'll go from there. We will reconvene in about 5 minutes.
Hi, this is Maddie. Sorry to interrupt. So we don't have the ability to do breakout rooms, but everyone can maybe think about those discussion questions on their own, or if they're watching with someone, they can discuss amongst themselves.
Perfect. Okay, so yes, after, you know what, let's think about that. Let's write it down. Let's jot down the challenging parts, the most effective parts, and then that'll be something great to reflect on. Okay. Okay, now we are going to jump into some case conceptualization. So case conceptualization can be a very important part of treatment planning, and it also can contribute to a very successful therapeutic outcome. So depending, of course, on your role, case conceptualization can be very, you know what, brief, or it can be a little more in-depth. Just slide up.
Mhm.
Okay. So we are going to look at a few cases that are kind of parts of what we've seen, what we've heard, and very common issues that we see in therapy. So we're going to look at our first client, Olivia. So she was referred to therapy by a pelvic floor therapist. So feeling a lot of anxiety around sex and also feeling a lot of dysregulation, a lot of emotions and distress when thinking about the birth of her daughter. So when we looked at the anxiety, it was impacting her day-to-day functioning. So feeling highly anxious most of the time, lots of intrusive thoughts, lots of worries about her daughter dying of SIDS. So Olivia and her partner, they bought an Angel Care monitor, Owlette monitor. They had like all the gadgets, all the tools that we have seen can often contribute to heightened anxiety, where people get fixated on those stats, on constantly watching the stats or monitoring the stats. And then also if false alarms do go off, that can cause a huge spike and just contribute to that overall dysregulation. When we look at history, Olivia
Sorry to interrupt. This is Maddie. You're kind of coming in and out. Would you be able to start?
Formally diagnosed as she reflects, but yes, for sure. Okay.
Sorry, you were just breaking up a little bit. So if you could just start that part over. Thank you.
Okay, no worries. So Olivia, looking at our first mock client. So she was referred to therapy by a pelvic floor therapist. She's feeling a lot of anxiety around sex, feeling a lot of emotional dysregulation when thinking about the birth of her daughter. So looking anxiety definitely impacting day-to-day functioning, feeling highly anxious most of the time, lots of worries about her daughter dying of SIDS, and also the purchase of the Angel Care monitor and the Owlette monitor. And that's something that we also see, that sometimes these monitoring devices, these tools can contribute to a further sense of anxiety, where people do become fixated and focused on the stats of that monitor. And of course, if false alarms do go off, that can contribute to a lot of anxiety. So looking then at history, she had a history of anxiety, nothing formally diagnosed is often what we see as well. But reflecting back, it's like, oh yeah, that did impact my day-to-day functioning, maybe more than what I had thought. Okay, so when we look at case conceptualization, we want to look at the presentation. So it would be anxiety and birth trauma. So what would be the precipitant to that? So it would be a traumatic birth, so unexpected interventions that happened, and an overall feeling of distress when thinking about that birth story. So what are some of her patterns of coping? So She used a lot of physical movement, coping with stress, baselines, usually positive self-talk, but recently has had a very self-defeating theme. We want to look at cultural stressors. No cultural stressors identified. Any social issues, so loss of mother, biological issues, previous pelvis injury, and psychological. So some tendencies of difficulty reaching out for help and patterns of perfectionism. Perpetuant. So with the use of that owlet monitor, Olivia's having consistently disrupted sleep, increasing the anxiety and stress, but she's also unable to discontinue the use of that owlet because the fear that, oh my gosh, if I stop using it, then it'll just increase my anxiety. And then we want to look at protective factors. So you know what, she's motivated, she's hardworking, she's determined, she's compassionate, and you know what, some healthy ways of coping with anxiety. So physical outlets, jogging, spending some time in nature. So some protective factors there. So the plan, what would the treatment plan be for Olivia? So we would mainly focus on relationship skill building, anxiety coping skills, and then also some supportive counseling for the loss of mom, and potentially some group counseling for other moms in that postpartum period. If the anxiety strategies, if some of those grounding strategies don't necessarily seem to be as effective as what we would hope for her anxiety around sex, EMDR can be effective. And then we will continue to reassess feelings around her birth story. And if, you know, with those feelings continue to present, we would probably utilize some EMDR for that as well. So what is EMDR? Some of you guys may have that question. So EMDR stands for eye movement desensitization reprocessing, and it changes the way traumatic memories are stored within the brain. And it's one of the leading trauma therapies out there today, and it is also recommended by the World Health Organization as one of the leading treatments for post-traumatic stress disorder. And we would also categorize some birth trauma as is fitting into that category if it meets all of the criteria. So EMDR uses bilateral stimulation to help process those traumatic memories. So just allowing the mind to just file them away as you would do with other memories. So it uses bilateral stimulation. So that's right, left, similar to how eye movements, rapid eye movements during sleep. So it helps make the memory less activating, less distressing. So it really can change and shift how those memories may live within you. And traumatic births don't necessarily have to mean just like a recent birth. We've both worked with moms that have had traumatic births from decades ago, where it still impacts their day-to-day functioning. And we've successfully worked through strategies to help them process that.
One thing to note with this vignette, we're kind of talking about it from our theoretical lens. So this is how we work with our clients. But this is kind of how to case conceptualize. So you can shift it to what methodologies you use in your scope of practice.
Mm-hmm. So the prognosis would be good given her strengths, her motivation, support, and we would anticipate that with continued therapy that her prognosis would be good.
Okay, so in terms of treatment planning for Olivia, there's some things to keep in mind. Again, it's going to be your theoretical orientation, what methodologies that you like to use in your own practice are adaptable to these situations. So again, because we're talking about it from our theoretical lens and giving you a case conceptualization of clients that we work with, it doesn't mean you can adapt this to how you work with your clients. There are so many effective treatment options and therapies that you can use. And so if you, for example, instead of using EMDR, you use brain spotting, that's okay. Go ahead and use brain spotting, right? There's nothing that says these specific treatments are the only treatments that you have to use. And so it's really important just to continue monitoring, seeing how your treatment plan is working and being flexible within that, right? There are times where other things in their life circumstances pop up and need to be addressed in therapy, or you might find little bits and pieces that slowly come out and that it's going to shift how you work. So, we really encourage you to go back and reflect on the treatment planning, check in with the client, continue to monitor those symptoms, and then, of course, think about, okay, is this working for the client? Can I adapt my approach? Or again, do we need some referral options, right? There are always that alternative. If you're finding that you're hitting those roadblocks or you're finding that your client is still struggling, there can be other types of modalities and therapies that may be beneficial for them to utilize. So then it comes back to what we were talking about earlier is, do you want to have that opportunity to work with a client a therapist who does another type of therapy? Does your client want to explore medications? Right? What are they kind of needing and tailoring that to them, of course. And so having that list that you can either provide to the client or you can, or you can just suggest them, send them an email, whatever works for you, whatever approach you want, but knowing like, okay, when do we feel like we're hitting that wall and when would another type of approach or another type of support be beneficial? All right, so we're going to take some time to go through some of the questions that we've been receiving, and then we're going to take a short 15-minute break before we dive into the second half. So bear with me. I'm just going to bring up some of the questions and we will go over them with you. So if you do have a question that you've been kind of thinking about, feel free to pop it in the Q&A and we'll get to as many as we can here.
Hi, this is Maddie. You're muted, so we can't hear you.
So what is considered the postpartum period? So we touched on that briefly earlier. So again, we're looking at the perinatal period. So sometimes, depending on what you're reading or the professional that you're working with, sometimes that's including the trying to conceive period. Often that's considered pregnancy to postpartum within 1 year of giving birth. So that's typically what the postpartum period looks like. Again, but we argue that it's really dependent on the client and what they're going through. And some argue that postpartum carries on, right? And we're kind of the belief that, things can arise in the perinatal period, postpartum period, and still be impactful later on. So it's really important just to be mindful of where your client's at. But if you're looking at a textbook, that's what the perinatal period would be.
Okay. How would you identify the differences between PPD and PPA? Symptoms can, yes, often be similar. Yes, you definitely can give the back depression and anxiety inventory. We like to have a conversation. Are you seeing more of those anxiety symptoms? Are you seeing more of the depression symptoms? Like, look at those symptoms. Is this anxiety? Is this depression? Or they overlap? It also can be both, right? That definitely does happen. Just because somebody is struggling with postpartum depression doesn't mean that postpartum anxiety won't exist there as well. Yes, so a lot of adopted mothers definitely do experience a lot of these symptoms as well. That is one area that we do touch on a little bit in our Instagram page, and then also foster moms as well. When, okay, you know what, maybe you haven't necessarily prepared to have a baby in your care for a significant amount of time, but yes, we definitely want to also acknowledge that.
And you're just be looking at some different grief and loss that can come around with that, depending on the circumstances of adoption, why they're adopting, how they feel about the adoption in itself, the infertility background, their family structure. So there's some different grief pieces that can come along with that as well.
Mhm. Okay. So Carly said she has a client whose baby is over a year and they don't allow any family members to kiss the baby, with COVID being so touch and go. Keeping in mind that, okay, is this some postpartum anxiety going on? A lot of factors going on. Of course, everybody, and this is what we've seen a lot, everybody's going to have certain thresholds and tolerances of what is, you know, an acceptable level of risk for Chelsea being in the NICU for 3 months. Her tolerance for some of that, you know, at the people kissing the baby is going to be less than maybe myself with my second, where I'm like, you know what, everything went really, really well. And then it's also going to depend on, you know what, do they feel supported? Do they feel safe with their family members? A lot of things can impact that, right? Mm-hmm. Okay, how big of an impact does past personal trauma, sorry, can you go up? Oh, sorry. Of the parent, especially sexual trauma, have on the presentation of postpartum anxiety? Yes, a big impact, because if they're not feeling safe in their body, then it is hard to feel safe sometimes caring for another individual. It can hard to be trusting other people with baby. It can be hard to leave baby. Personal trauma, sexual trauma can impact a lot of those behaviors that we see with postpartum anxiety. And then again, it would be, okay, do we need to work through some of this trauma that is contributing to the postpartum anxiety?
If a mother did not have PPA with her first pregnancy, are there chances of having PPA reduced in subsequent pregnancies compared to a mother who has had PPA in their first pregnancy? So it's really interesting. We kind of think of it more as risk factors and protective factors, because we can't guarantee, regardless of how a first pregnancy went, how subsequent pregnancies are going to go. If they have anxiety in the first and they didn't have it in the second, and vice versa. So we're really looking at risk factors. So it could be dependent on, so not having it in their first pregnancy would be a protective factor, and having it in their first pregnancy would be a risk factor. That being said, if there's other factors, for example, if the second pregnancy, they have a lot of negative feelings around it, they're feeling like they don't have support, they don't feel as though they intended to get pregnant, for example. So there can be a lot of different factors that are going to be influencing every pregnancy. And so instead of being aware of it is absolutely important, but thinking about it in, okay, what are the risk factors that they have for this pregnancy, and how is their first pregnancy going previously, and then contributing that into the second pregnancy. Hopefully that makes sense.
Are the survey stats for Canadian mothers or USA population? So the research article that we shared, where it was postpartum anxiety and postpartum depression that increased from, I think it was 17% to 40, and then postpartum anxiety was up to 72. That was a Canadian study. So it was Canadian participants.
Are what ifs considered intrusive thoughts? Yes, that would be what we would consider an intrusive thought, right? There's a lot of what if this happens? What if this happened? This could happen, right? So the what ifs can always be part of the intrusive thoughts, for sure. Do fathers feel like this as well? It's interesting because just as the research is limited on moms, it's also limited on dads. So it is being more researched. So I believe the last statistics were 1 in 10 dads experience postpartum anxiety or postpartum depression. And so there are factors that are going to be similar. Sometimes the way it presents itself can be different, and the things that they're focused on and that they're worried about can be different, but they can definitely experience anxiety for sure.
Okay. What type of therapists are able to give the assessments listed on the previous slide? So we know we're speaking for ourselves, we're psychologists in Alberta. I would check with your regulatory body, but if you are a registered health professional, I would think you would be able to administer those assessments. But of course, every province, every state will have different criteria for that.
Okay, we'll just answer a couple more and then we will take a break. We will be touching on postpartum rage next. So that is our whole next session is rage and burnout. So it's coming, I promise.
How do you suggest working with someone who is limiting partners' access to their child due to their own anxiety? So we do see this a lot. So what are some things that would be considered, what can dad or partner help with? Maybe they can help with getting diaper ready, getting the cream ready. So we want to just work the way up that scale. So we want to give them, some of those like smaller tasks. It's like, okay, dad did this, dad did it well, and then work the way up the ladder too. But then also addressing that in the process and talking about that as being, that is a part of postpartum anxiety, is gatekeeping as well. Teen moms, yes, absolutely. There definitely would be a lot of factors that go along with that as well.
Yes. So the question was, anxiety here is focused on intrusive thoughts. It's a very big component, but there's also physiological manifestations. The last part of our presentation is some of our foundation strategies that can be used. So we go into this a lot more later on. So if you have a question about it later on, feel free to ask. We do have another Q&A period or two. So if you don't feel like we answer that question, let us know later on, but we have lots coming up on that. Okay, one more. Oh, maybe this one. Right. So what is the average length of time before symptoms may resolve with or without treatment? Do they resolve the first year? So we don't have a solid answer for that. So there's some things that I would encourage you to consider. So one, we often look at the symptoms can definitely start in the postpartum period and carry on for years later. So, we'll often have moms come in who their child's 4, 5, 6, 10, and they're like, I still feel this way. Like I felt like this since I gave birth, right? And so sometimes it does go into like what we would look at as like more perpetual state of anxiety. Really the perinatal period, like that we put on top of that, or perinatal anxiety, we're really talking about when the symptoms started. So they could still have anxiety that's continuing on, but that perinatal piece is really focusing on when those symptoms arose. And so sometimes if the symptoms do get better, they can get like naturally get better over time? Absolutely, right? It depends on the person. It depends on what they're doing on their own, how they feel, right? That tolerance for anxiety, all of those factors that can come up. But that's why if you do have a client that's coming to you and they're like, again, further down, their children are older, we want to talk about that perinatal period. We want to talk about their birth experience. We want to talk about, how was their pregnancy and their trying to conceive journey, because all of that could be factors that are still influencing them today. All right.
Okay, well, we will take a 15-minute break-ish. We will come back at about it's 1:22 our time, so 1:40 our time. I think that would be 3:30 Eastern, 3:40 Eastern time. Hey, we will see you guys in 15. Okay, welcome back, everybody. Hope you were able to stand, stretch, get a drink of water, coffee, whatever you needed to do to feel energized. Okay, so this is coming to one of my favorite parts that is one of the things that aren't talked about commonly, that we are seeing now moms starting to share their experiences with. Hey, anger. So when we talk about anger, we're looking at it as a very, very normal human emotion. Okay? So often anger gets a bad rap. It's feared or regarded to as bad, or moms shouldn't get angry. So anger isn't a bad emotion, really. There's no such thing as bad emotions, but it can often be a warning sign. So all emotions, right, they're trying to tell us something. They're serving a purpose. Anger may be telling us, we haven't been treated fairly. We may have a boundary that was violated, or it's letting us know that, hey, you know what, some things need to shift, some things need to change. So it can be a sign of, that unmet need, boundary violation, or burnout as well. Okay, so mom rage. So it's kind of a hot term that is in social media a lot. There's some discussion like what is mom rage? What should moms be angry about, right? What part of that is validated and justified? But it really is kind of that catch-all term used to describe the anger that moms can feel. So it can pop up in pregnancy. It can also pop up in the postpartum period and throughout the parenting journey. So very, very common experience, but it does not mean that people have to suffer or power through it by themselves. Okay, so postpartum rage can be a scary experience, especially for somebody that maybe didn't really experience a lot of anger prior to children, to giving birth. It can cause people to feel disconnected from themselves, and that they're spiraling out of control. So it can often be a slow burning anger that's just kind of like sizzling under the surface and then explode when something, unexpected happens, maybe something a little bit smaller. Or for other people, it can be very explosive type of anger. So often what we see is moms saying, I'm just feeling so irritable, so on edge. And that one thing, right, that broken glass, that spilled milk, the red light can result in an explosion of feelings. Okay, so when we look at mom rage, we need to look under the surface. So what people see is that, being snappy, being irritable, just yelling. But what is underneath that? There can be society expectations, the mental load of motherhood, trauma, depression, burnout, all of those things underneath the surface can contribute to the behaviors, to the responses that you see. Okay, so these are some images on social that we've shared that get moms talking, that get moms saying like, hey, me too.
And you can access them on our social media if you'd like to. Just screenshot them.
Yeah, screenshot them. You can, you can print it out, share it with moms. We find that visuals are much more relatable to moms. So what does this rage look like? So it can be outward, right? That's kind of the rage that gets the attention, that makes people go, whoa, what's going on? So snapping, throwing things, yelling, just, ups and downs. It also can be inward signs. So some of those intrusive thoughts can get a little bit worse. Anxiety, low mood, low self-worth, a hard time concentrating, and then it can present very, very somatically, very, very physically as well. So heart racing, just feeling tense, on edge, headaches, stomach in knots, feeling nauseous. So it can become very, very physical as well. Okay, so why isn't it talked about again? So up to 35% of moms report feeling that anger at around 6 weeks postpartum. So why don't we talk about it? And again, there were some questions about the research. So all of that research, it's in our references. So it is all cited there. So looking at mom rage, it can be uncomfortable and people can feel shame around that level of anger because it can be seen as incongruent with, what that mothering role, that nurturing role, that mom always, can handle the tough stuff. It can cause a lot of frustration towards self when it's like, I can't handle the tough stuff. And I'm raging on top of that. And that's sometimes when we see social media be a bit of a barrier for moms, because social media, as we know, it's that snapshot. It's that quick picture of Joanne from high school cuddling her kids and making the perfect smoothie and creating these picture perfect meals, which of course we know is a snapshot of a moment in time and does not reflect reality. But this can cause postpartum rage to occur in secrecy because it's like, oh, all these other people aren't experiencing it. Why am I? And that goes back to the comparison trap that can consume thoughts that can lead to that vicious spiral. So everybody else looks so happy and my partner and I fight all the time. I don't make home cooked meals. My body didn't necessarily bounce back like so-and-so that I saw on Instagram. Comparison around my house is such a mess and I'm seeing all of these like perfectly curated white kitchens all over the place. So all of those thoughts can contribute to those feelings. So the comparison trap is so real in modern motherhood because it looks different than it did 30 years ago because they weren't able to pull up their phone and see what so-and-so served her kids for breakfast. They actually had to call and see, which didn't typically happen. So modern motherhood and social media can be a comparison trap. Okay, so common sources of rage, society, huge, huge, huge one. Work, home life, right? Trying to show up at work and mother work like you don't have kids, and then parent like you don't have a job to go to, right? Social media, seeing what everybody else is doing. Family dynamics, what is the support like within their home, or do they have support outside of their home? What is that relationship like with their extended family? And of course, their own past. How was anger expressed in their home? Was it allowed? Was it a lot of rage? What did that look like? What did they see in their upbringing that often can come up when parenting children? I know even for myself, I found my mother coming out of my voice. And I'm like, I've never said any of those things before. And it's phrases like I've had it, and just different things that I never said. And all of a sudden I have 2 kids and it's like, oh my gosh, okay, my mother. But it also shows how influenced we are from our own upbringing. Okay, so underlying concerns of rage. So that goes back to some of that anxiety, that depression, the burnout that can really be the simmering things underneath the water that contribute to rage. Okay. Again, the mental load. We talk about being the default parent a lot, and that's what moms, and especially new moms, find that I'm the default parent. I'm the go-to. I'm the one that feeds baby. I change baby. I wake up at night. I just have the load, and it's heavy, and I don't have a lot of sleep. So that can contribute to just feeling that inequality in parenting. If there's not a lot of support, and that's what we saw during the pandemic, where people weren't able to have some supports come into their homes and help them with the day-to-day things, or even just, what, well, baby, will you go have a shower? So we are bringing some of that back now, luckily, but that's still, those 2 years greatly impacted moms during that time. And again, the cognitive distortions and getting stuck in that negative thought pattern can really be a trigger for rage. And again, work life, sensory stimulation, past trauma. Some of those triggers for anxiety can also be those triggers for rage as well.
So one way we like to look at anger is really name it to tame it, right? We want to take the shame and the stigma and the guilt out of the anger, right? Anger is a natural, healthy emotion. And it's, again, that indication of something is missing or something's gone wrong. So we want to give ourselves, or encourage our clients to give themselves permission to experience that anger, right? We want to find healthy outlets and what that can look like for them. And again, we'll dive into some of that a little bit later, but we want to provide space to let the anger or the angry thought come and go, the feeling of anger come and go, and take the pressure off, right? We want to allow them to know that there's no need to avoid it, right? Again, anger is uncomfortable. We don't want to feel angry. We don't want to feel rage, right? It's hard to feel like that burning sensation underneath in our feelings. It's hard to wonder why we're feeling the way that we're feeling, or even feeling out of control, right? A lot of anger can feel really dysregulated. And of course, looking back on how we were taught about anger, or how we were taught to express anger, can really impact how we feel like we can work through it. So with finding those healthy ways to express anger, we find that this cycle can be a really effective way when working with your clients to understand it, validate their emotional experience, right? When we think about being in tune with our children, it's something that we are so skilled at. We pay attention to their emotions, we pay attention to their feelings, we validate them, we provide space for them, right? But we're really bad at doing that for ourselves. So it can be a really nice way to help your client learn to do that for themselves, and to know that anger is healthy and anger's okay. So again, name it to tame it, give permission to experience anger, provide space for it to be there, and then expressing it in a healthy way. So this is a cycle that you can work with through your clients if they're coming to you and expressing that they're feeling quite angry. And paying attention, right? Really being curious about the anger. And again, that might be what your role is, right? Your role might be, hey, let's explore it. Let's talk about it. Let's kind of externalize it a little bit and look at it through a magnifying glass and see, okay, what's going on for you? What's triggering the anger? What beliefs or core beliefs might be activated under the anger? So these are some questions that you can consider when looking at anger and when supporting your client in understanding what they're going through. So some common behavioral outcomes that you'll see with anger is suppressing emotion. So most often expressing anger, right? They don't want to feel angry. They don't want to express that it's happening. It's again, the bubbling under the surface, right? It's there and it's probably impacting how they're feeling and how they're behaving, but they don't really want to let that out. This often comes with neglecting needs and trying to push through, right? It's like, okay, if I just ignore it, it's going to go away, which we all know that typically is not how it works, and it does not go away. Ignoring any warning signs. So this could be something like, they know when they're angry that they clench their fists, their jaw gets tight, right? That body tension. This can come up in so many different ways, but they're really ignoring the warning signs because they don't want to acknowledge that it's there. And so this can then lead to explosive behaviors, right? It's you stub your toe and you explode. Your kid knocks a cup of milk off the table and it's like, my lid is flipped, everything is gone, right? I cannot regulate myself anymore. You're also going to see exhaustion, right? Emotional, physical, and cognitive exhaustion. You can feel like you're kind of at the tail end, right? They come to you and they're like, I don't know what else to do, right? I don't know how to feel like this anymore. I don't know how to make it better anymore for themselves. And that anger can really be manifesting in some of those other ways. Resentment is a huge piece of anger, right? Again, when we're going back to those needs, we're looking at, are your needs being met? If they're not being met, or you feel like your partner is able to meet their needs and you're not able to meet your needs, the client's going to come to you and say, I feel resentful. I feel angry. I feel like I don't have freedom in my life, or I don't have the space to make time for myself. And I feel like everybody else in my life can or does. And that can be that, again, that bubbling frustration that can come up. So it's going to impact those relationships around them, because they can also withdraw, right? They avoid, they're like, I don't want to deal with people. It feels safer for me to not be around anybody. It feels better for me to just, stay at my home, stay in my space, and I'll not be around and express myself, or I'm scared I'm going to lose it, right? Is some of the language that you might hear. And then, of course, avoidance, right? They might avoid people or places that are triggering for them, similar to anxiety, but ones that are going to cause the anger, right? Like if they feel like overstimulated and frustrated by going to the grocery store, maybe they can't get to the grocery store. If they're family members, they feel, again, that resentment and frustration and feeling a lack of understanding, then maybe they avoid going to places or answering their phone, or, anything that they notice that anger start to bubble up, they're probably gonna withdraw from or avoid going to. So again, we want you to take a minute and just think of some of that anger. Think of ways that your clients that you've worked with have expressed anger. And allow yourself just to jot some things down. Again, we're going to go into more strategies after this because it ties into burnout. So we're going to go into that, but we just want to give you a couple minutes just to jot some things down, kind of do a little case conceptualization a little bit if you have somebody in mind. And when we dive into burnout, we'll go through some more strategies that will help with both anger and burnout. Okay, so we're gonna do some more case conceptualization. So this might help with some of the questions that we just asked, and some ways for you to think about it. And so this is related to a client that I've had before. So Andrea came in and scheduled an appointment, and she was speaking with her primary care physician, so her family doctor. She had noticed that she was getting significantly more angry than she had previously, and it was related to her partner who was out of town for work. So she was finding that this anger was impacting her day-to-day functioning. She felt more reactive than normal. She was having trouble managing after having her second baby. So she was about 2 months postpartum at the time. And she was reporting that she felt a lot of frustration with her older child, which led to a lot of feelings of shame and guilt because she would kind of lose it and become reactive to her older child, and then feel a lot of guilt and shame. So Andrea had a history of negative self-talk, some experience with low mood, anxiety, and anger, but again, no formal diagnosis. She was just working with her family care provider to monitor the symptoms at the time. So her presentation was anger and difficulty regulating her emotions. She felt like this was the precipitant of this was the birth of her second child, because she felt previously that she was managing quite well when her husband was out of town, and she was able to regulate better, get some time for herself when she had only her first child. But after her second, she felt like it was a lot to juggle and manage. So her pattern of coping before she would use exercise and connecting with friends, she had a baseline of some negative self-talk and feelings of inadequacy, but she felt like overall it was fairly regulated and managed, and it wasn't impacting her day-to-day life too much. So she was from a religious background, but she had removed herself from that religion and she was no longer practicing. And for social, she did have difficulty connecting with friends always. So she felt like she was missing some of that social support. There was no biological factors that were necessarily impactful at the time. And from a psychological perspective, she often had difficulty reaching out for help and managing her feelings when she was overwhelmed. So some perpetuants for her. So because she was newly postpartum, Andrea felt like the sleep deprivation, the juggling the new role of having 2 children, and also the lack of support with her partner frequently working out of town were kind of impacting that rage and that anger. So some protective factors that she had: Andrea was great at self-awareness, at insight. She really knew her emotions. She was able to label them and identify them. So she had really good self-awareness and was very motivated in creating that change for herself. So she really wanted to see some shifts and things be different for her. She did have a good support system when her partner was home. So when he was home from work, she felt like she had a bit more of a balance. And her older child did have access to daycare 2 days a week. So she did have some space that way. But when the partner was away, she didn't feel like she had that kind of support that she needed. So the treatment plan was mainly to focus on proactive strategies. So we wanted to explore what needs weren't being met when her partner was away out of town. We also wanted to explore ways to help her meet these needs and see what that could mean for her, right? Because if, when her partner's out of town, she wasn't able to, change, have a glass of water, eating was not a priority, right? All of these basic needs that she would try to prioritize felt like they kind of fell to the wayside. So it was exploring those needs with her and finding ways that we could meet these needs, and also being creative in, what was going to work for her and the timeframes that she had, right? Because anybody that is a single parent or does have a partner that works away from home knows that sometimes when you don't have that resource or that support or somebody to watch your children when you're in the shower, it can feel really overwhelming to find ways to meet those needs. And that overwhelm in itself can help perpetuate the anger. We also wanted to find ways to emotionally express her anger in a positive way. So what are some outlets that she could have? And again, we'll get more into those proactive ways in a little bit. So overall, her prognosis was good because she had a lot of strength, a lot of motivation for improvement. And it appeared at the time that with going through the treatment planning and focusing on those strategies, that she should notice some significant improvement over time. So that was a way to monitor her change. In terms of referral sources, so what we wanted to focus on was more of that community resources, those online resources, and finding ways for her to build that social support, because that was one of the things that she felt was lacking, but also felt like being able to be social was difficult when her partner was out of town. So it was kind of that balancing act, right? So some referral sources that could be very beneficial in that instance, or for somebody in those circumstances, would be utilizing those online resources because they're at your fingertips. And also community resources where you can bring your children, or mommy connections groups, or different play groups, different activities, swim lessons, whatever, different things like that, right? Where baby could come with her and she could also get out and meet new people. All right, so we're just going to take a minute just to go over some questions in regards to anger. We are again going to lead into burnout right now. So if there's one stemming into that, we will be getting into that, but we're just going to go over if there's any specific anger related questions. Is rage associated with hormonal shifts at all? It definitely can be. Sometimes you'll find when, if a mom has been breastfeeding or pumping or anything like that, when the weaning happens or that shift happens, sometimes in that hormonal shift, you will notice an increase in rage. It definitely can be a factor, but it's usually not the whole picture. Like, it's not just a hormonal shift causing that, but we definitely do also refer to a family physician to rule out any physical factors that could be impacting the rage as well.
And would postpartum rage be part of postpartum depression, or can it exist outside of a depression diagnosis? Absolutely, it can be part of postpartum depression, but then it also can exist without having that depression diagnosis. So that's one thing that we see, that we would say that's a result of some of those unmet needs of constantly, you know what, mom is coming in last, and mom, maybe life looked like she could go to the gym, she could do this, she could have a good sense of control over her routine, what her day-to-day looked like, but now having kids, it's a lot harder to meet some of those needs, or to have some of those coping outlets that she did in the past. So at times that's when that rage, that mom rage, will come up, because those needs have been unmet for such a long period of time. Yes, and definitely behaviors are very common for caregivers of elderly parents as well, and can be incredibly tough for those people that are caring for young kids, but then also caring for older parents. I think that sandwich generation, right? So kind of burning the candle at both ends, definitely.
Do you want to talk about the steering strategies?
Mm-hmm. Okay. Yes, we will go into healthy ways to express anger strategies in the last portion of it.
Yeah, a lot of moms do say that they're asking for help. That's kind of what we were talking about, the societal expectations, right? This idea that mom can do it all and mom's amazing, and, you know, all of that like positive reinforcement. And then mom's there like, I'm drowning, like, help me, help me. And so that's why it's really important to talk about the societal expectations, right? It's important to say, you know, what messages have you heard? What maybe is contributing to you feeling that way? You know, do you feel like that's influencing you or not? And so that can be really challenging for moms, because they feel like there isn't that support there, for sure.
Mm-hmm.
We can get into that.
We'll get into the brain changes in the last bit too.
We can do that one after too. Can breastfeeding lead to postpartum rage? So breastfeeding is a little bit interesting. There's kind of this dual relationship, right? It can be a protective factor and it can be a risk factor. So it often depends on circumstances and how breastfeeding is viewed, how the journey goes, what's happening for mom, if they want to breastfeed and are able to, if they don't want to breastfeed. So there's a lot of factors that can go along with breastfeeding. That could probably be a mini topic all in itself.
That could be its own webinar.
But yes, so breastfeeding is definitely a factor. So again, just try to remember that there's that dual relationship. It can be both a protective factor and a risk factor. I mean, for myself, I was an exclusive pumper because my son, again, was in NICU. And I remember sitting at the bed and I was so angry. I was so angry that I had to pump and I had to do this. And I was about 10 months postpartum. And that was my sign. I was like, I actually can't feel like this anymore. And I decided to quit pumping. So, you know, I knew it was making me angry, or made that connection. I guess I didn't probably realize that right away, but, you know, it is really good to have those conversations around, you know, how are you feeling about it? And how do you feel like it might be impacting you right now? And of course, those hormonal shifts that we had discussed a little bit earlier as well. Sensory overwhelm.
Okay, what contributes to sensory overwhelm? Well, motherhood is loud. It creates a large sensory experience, not only with auditory experiences, but think about smells, think about all of the control that you had before being a mom, that you could control who you were around, how loud they talked. You could turn the volume down. If there was a crying baby, it's like, okay, I'm going to give them back and leave. But okay, now the baby is ours and the crying won't stop. And we feel that in our body, and we feel the anxiety get a little bit higher. Right. So, and like you said, when there is that history of trauma, when that body awareness is difficult, how can we incorporate, you know what, and we'll talk about this later, but some sensory breaks, right? If the overwhelm is so much that it's hard to think, if she can feel like, oh, my thinking brain, the prefrontal cortex is shutting down. Hey, can we put baby in a spot and can go take a break, some cold water? How can we calm the body down when you're at that level of complete sensory overwhelm, right? And it's hard because sensory overwhelm before looked probably different than it does after, babe.
We'll do a couple more. Do you see PPD, PPA, or rage shift into PMDD with returns of the menstrual cycle? In terms of that, I mean, it definitely depends on their medical history. If they were experience PMDD, it definitely could be an influencing factor. But it's a little bit complicated because there's a lot physically that's happening with PMDD. And so there's a lot of other factors too that could be influencing, like pain, for example, right? Discomfort that can impact anxiety, depression, and rage. So there's definitely components of that when PMDD occurs.
Just do that one. Okay. And I think this is a really important question. So is it possible that childhood trauma triggered during the postpartum period comes up? Yes, absolutely. So when you have a baby and you know maybe that support doesn't show up for you, or often we see parents, they reflect on their own childhood experiences and how their needs weren't necessarily met. Or if there was a lot of trauma in their early years, they can't imagine, like, oh my gosh, not protecting their child. And that can trigger some anger and rage towards some of those family members as well. Whereas perhaps some of this was just, put away, contained to the side, but having a child forces a lot of those things to resurface. Okay, we will continue on with burnout and coping strategies. Just being mindful of the time, and then we'll get to as many questions as we possibly can at the end.
So when rage becomes burnout, I'm just going to say it backwards. So what is burnout? What fuels burnout? It's one of those hard to discuss topics sometimes because a lot of people will say it, right? Like, oh, I'm so burnt out or I'm so exhausted. So we really want to dive into, what does that mean? And what does it really look like for people who are experiencing it? So when we look at clinical presentations, what we're really looking at is how prolonged the symptoms are and what is happening day to day for them. What are some of the symptoms they're experiencing? How intense, how often? So some things that you'll notice if your client is experiencing burnout is a lack of energy. They have difficulty doing tasks. So they feel like you'll often hear like, I just got through the day, right? Like I just went through the motions and managed the best I could. There's often a lot of feelings of hopelessness. So difficulties viewing that things can get better and difficulty that, you can see the light at the end of the tunnel, so to speak. There is the idea that doing anything from themselves seems impossible. So you might have that client who is like, I've tried everything and nothing works, or I did this and I didn't feel better, right? Like there's that difficulty in feeling like change can happen and that doing the strategies is going to create change. Mm-hmm. They're also often quick to anger. So that's where that anger piece comes out. So that's like one of the red flags that we're looking for. And then there's often a lot of personal judgment and shame. So feeling like they're not doing enough, and that is contributing to why they're feeling the way that they're feeling, right? Like if I was better at managing my life, I wouldn't feel this way. Or if I was better at time management, right? You'll hear some of that kind of language. Intimacy is often lacking in their partnerships, relationships. They often feel like they will turn to strategies that can numb. So you'll hear like, I just zoned out on the TV, or substance use, or different things like that. And then of course, withdrawing from friends. So friends and family. So they don't really want to be around anybody, right? That takes a lot of energy and effort to, sometimes we call it like masking or different things like that, where, they put on the happy face, but that takes so much energy that they aren't able to continue to be engaged.
Okay, so when we look at burnout, I really love this visual of the mom with the babe, with the cooking utensils and the stack of things that she's trying to juggle. So it really conceptualizes burnout, parental burnout specifically to a T, where those demands are so high. Right, she's on the phone, she's trying to cook, she's trying to take care of a crying child. There's I think a briefcase in the background. She's probably just came out from work and she's juggling all the things. But then those demands are so big, but then the help available is just so small. They can just lift you up a little bit, but it's not what that person needs. So again, this can be a visual that you give to your client, you show them that they can be like, oh yeah, that makes sense. They feel heard and seen. So going through some of those symptoms, right? Exhaustion, doing something for yourself that seems impossible. Are you overwhelmed by your emotions, right? That low motivation. So visuals can really help, like, oh yeah, this definitely is me. Okay, what can help fuel this burnout? So society, family, personal expectations of being the perfect parent, lack of support community, being a people pleaser. That's often what we see in a lot of clients, especially females. They were, you were brought up and it's like you say yes to people, you be a good girl, you help whenever possible, and they sacrifice their own needs for others. Default parenting, being the parent to do all the things around the home, plan the birthday party, make the appointments, do the grocery shopping, being the one that's sitting on the couch and the kids are crawling all over, and maybe partners over there too, and there's no kids on them. Circumstances, right? If there is a child with medical needs or a neurodivergent child, this can add additional circumstances, stressors, appointments, different needs. So a toxic work environment that can influence how you feel outside of work, that can impact how you also feel at home too. And again, that unmanageable workload where you feel like I could multiply myself by 10 and I still wouldn't have enough of me to go around. Okay. And then of course, financial insecurity that's plaguing so many of our clients that we see. Food insecurity, housing insecurity, all of that instability can really fuel burnout as well.
So this is a really nice visual that you can draw out for your clients. You can use as a talking point, and it's really how we like to talk about burnout with our clients. It's, are you burnt out, surviving, thriving? And what does that look like? How can we know which area that we're in? We love using visuals, like we said earlier, right? So the stoplight can be a really nice way to say, okay, are you in the green light? Are you in the yellow light? Are you in the red light? What can we put in each light that you can use as a way to identify what you're experiencing and what you're going through, and really have that awareness piece and that insight to hopefully catch it and be proactive, or help work yourself out of it if you're in the burnout. So again, burnout, surviving, thriving. You can reverse it if you want. Thriving, surviving, burnout, doesn't matter. Whatever, however you want to draw your stoplight. But yeah, this can be a wonderful visual to help start those conversations.
Absolutely. And having that conversation, what does it look like when you're burnt out? Because it'll be a little bit different for everybody. What does thriving look like? Like, what does it look like when things are going well? And what is that kind of cusp where I'm just kind of getting through, not burnt out, but not necessarily great either?
So when rage becomes depression, so we're just going to touch on this a little bit because we're not doing a deep dive in depression. Obviously, that could be its own presentation, all of it in itself, but it's important to be able to distinguish, okay, is this a bit of burnout? Is it a bit of depression? Is it a bit of both? Like, what's going on here? So what can depression look like? So some outward signs that we're looking for are that emotional dysregulation, emotional outbursts, bursts, withdrawing, changes in sleep, and changes in appearance. And so, you know, sometimes you'll have a client, for example, who will come in and let's say they normally really like to dress up. That's one thing that you just know when they're feeling good about themselves. They, you know, get their nice shoes on, they get their favorite shirt on, and they just seem like they visually look kind of put together in a way that they feel like that makes them feel good. And then they come in one day and their hair is a mess and they're in sweatpants, and you're like, this doesn't seem like how you normally would like to dress. And of course, there's obviously the visuals that you can look for, and changes in skin tone, you know, how are their eyes looking, different things like that you can use as kind of a guide for that. Also changes in sleep. So again, this one's hard, especially for new parents, because sleep, as we know, is hard to come by. It's lacking often. It's a fuss. I always tell my clients, this is going to be a frustrating question, but are you able to rest or sleep when the opportunity presents itself? So if baby gets, you know, an hour stretched, are you asleep, or are you finding that you're struggling and staying awake and not feeling like you can shut your mind off, right? So that's one way to kind of look at it. Inward signs is negative thoughts, low mood, low self-worth, difficulty concentrating, hopelessness, lack of energy. So we're really looking at, you know, what's their internal dialogue, what's their internal perspective, what are their beliefs and thoughts about themselves. And then, of course, some physical changes as well. So changes in eating, some teariness, often tension or headaches that can cause physical pain, right? Sometimes you get that like TMJ. So different things that you can explore and you can look at with your client. So postpartum depression versus regular depression. So what are we kind of looking at? So again, this is really, we're looking at when the when the symptoms are rising and when it's kind of being diagnosed or you're looking for these symptoms. So that perinatal depression is the depression symptoms that are specifically in rising during the pregnancy and postpartum period, or they're intensifying. So if your client had regulated depression before, like they're like, it's managed, I'm on medication, I got my coping strategies, everything feels pretty good overall. And then during their pregnancy, they notice an increase in symptoms, they have difficulty managing, right? That could be considered postpartum depression. So again, any depression diagnosed outside of this period of time is a major depressive disorder. But again, look at when the symptoms arrive and how long they've been going on. That's the only thing that we're looking at here. So what's the difference between burnout and depression? So again, this is really nuanced. It can be really difficult to understand or to really know for your client. So some things that we want to look at are the overlapping symptoms, of course, but also consider the source of the stress that they're experiencing. So burnout is often linked to external stressors. So external stressors, we're talking about, work, parental load. You may have noticed in some of the descriptions that we were using and that we were talking about that those were a lot of external things and influencing factors, right? Family relationships, family dynamics, different things like that. With depression, there's obviously that physiological, internal, and external process. So even if, let's say, you decrease the external stressors, so work starts to get better, the depressive symptoms aren't necessarily going to just go away or improve. But often with burnout, you will see an improvement when some of that workload is shifted or changed.
Absolutely.
So again, what is diagnostic and what's normative? Because all new parents are probably going to come in and say, I'm exhausted. I've never felt this level of exhaustion before. So one thing, again, similar to anxiety that we want to keep in mind is how much is it impacting their day-to-day life, right? Again, are they isolating themselves? Are they withdrawing? Are they not engaging with, their life and the things that they normally enjoy doing? And how distressing is it to them? Like, do they have that awareness where they're like, again, that hopelessness of this situation isn't going to get better for me. I don't know how to climb my way out of this. I feel like, I'm angry or I'm not connected with my family or even having trouble bonding with my child, right? There can be so many things that feel really distressing to them. And it's important to see, what they feel like that level is and exploring that with them.
Okay, so we went through all of that information: postpartum anxiety, burnout, intrusive thoughts. So before we get into the coping strategies, we just want you guys to have a few things in mind. Everybody is different, and we realize everybody is coming with their own theoretical orientation that will influence what strategies that you do utilize. And you know what? Explore what is realistic, what works for your client. Not everything is going to, not everything is realistic for them at that time, perhaps. But you know what? Look at the different ones, take what you like, leave what you don't, and just really make it your own. Oops, fast. Okay. So we're going to go over the foundational themes, the strategies that we want you guys to have in your toolbox. And these really are the building blocks, essentially, for your client to create the strategies that fit into their lives.
Okay. So core beliefs is a really big theme that you can explore with your client, right? This is going to influence their view of the world, in view of what's going on in their life. It's also going to impact their views of self. So when we're looking at their core beliefs, we really want to see primarily what their negative core beliefs are and how it's impacting their ability to cope and manage day-to-day life. So thinking back to some of those cognitive distortions that we had been talking about, some of the past trauma, all of those things are going to influence that core belief. So the one way to really look at it is it's kind of like putting on a pair of sunglasses, right? Every shade is a little bit different. The color can be different depending on what sunglasses you're wearing, and that's going to influence how you view the world. And so it's really important to say, okay, what are your sunglasses and how are they impacting you? So that's a nice visual that you can use with your client when exploring core beliefs.
Okay, so this is my favorite one. Lowering the bar. So if your client is struggling with perfectionism, expectations, what does their bar look like? Because their bar before kids maybe up here, and maybe they were able to maintain that bar, but now newborn baby, maybe they don't have the support that they thought they would. Their bar is going to look quite a bit different. So how can we help them lower that bar? Because there simply just isn't enough hours in the day to keep the house clean, to keep the kids fed with great healthy, nourishing meals, and to be that model employee, and to keep friendships outside of the home and do things outside of the home. So it goes back to having a conversation about what are their values, and exploring this can help establish what their priorities are, and can be a guide for, okay, what is important to me? What do I value? I'm going to put that, at the top. And maybe it's playing with my kids and maintaining friendships outside of the home. And then maybe we get takeout for dinner, right? It's having that conversation that the bar can't always be up here. And maybe it needs to be down here for a little while, because this is a harder time, right? And exploring whose expectations are these, right? Is it theirs? Is it society? Is it their own extended family? Who's putting these expectations on themselves? Okay. And then, flexibility, learning, okay, how can we increase that flexibility in terms of what do we need, what do we want, and what's also realistic? Okay. And then those core beliefs associated with those expectations as well. Oh, this is one of my favorite visuals. So it's like, how do you do it all? You don't. So sometimes things will be dropped. Sometimes things don't get done. Sometimes we eat mac and cheese, right? Sometimes it just doesn't all get done. So it's just a nice reminder. Okay, so setting boundaries is so important, and a hot topic that we see lots of people struggle with, setting boundaries with their partner, with their kids, and with external friends, family, all of those people, right? So we want to explore what are the boundaries that they need to set, and who do they need to set them with. And different people that are in their lives, they may have different boundaries for. So their boundaries for maybe their mom is different than their boundaries for their mother-in-law, and that's okay. And learning to set these boundaries can help clients just decrease those feelings of, oh, I shouldn't set this boundary. I shouldn't take care of myself. I shouldn't do this. And once we see that, they're able to set that boundary and say, like, no, actually, I can't come help today, or no, you can't stop by. That can help improve burnout and anger. Okay, so distress tolerance. So depending on your theoretical orientation, you'll have different strategies that maybe your favorites for this. So this can be a great framework in just, developing some of those coping strategies. How can we help them feel that sense of calm and safety in their body? Maybe it's through mindfulness. Maybe it is just noticing those sensations in their body. Maybe it's visualization, right? So we want them to find that sense of calm, that sense of safety when they feel that, oh, the distress is up here and all over the place. So how can they ground themselves? Again, using all their senses. So we know there's going to be challenges as people continue to parent. There's going to be more. It's not going to stop. Different things are going to arise. So we also want to see our clients' window of tolerance get bigger, have more capacity, and then you will see that improvement in the ability for them to cope or utilize some of those strategies when that window is widened through the use of grounding, through the use of mindfulness, of finding some calm, of developing some positive mantras to help them through, when those tough times. Okay. Prioritizing care. We know self-care, it's a hot topic, and lots of people feel like, oh, I just have to have like a bath, that'll solve everything. And it's like, no, of course not. This is going to be different for everybody, but parents need to find a way to have their needs met, to still have things prioritized for them. So it's going to look different for each person, depending on, time, depending on resources. And we want to explore what is realistic for them. And we want to make sure that they're doable and that they can fit into their life and can be something that's proactive. So if they have, 10 minutes, what can they do? If they have an hour, what can they do? If they have no idea how long the baby is going to nap for, but they have however long that's going to be. So what's realistic for them? In our book, we have lists of, self-care when you have 5 minutes, 10 minutes, an hour, half a day. We go through all of those strategies. Do you want to do this?
Mm-hmm. Yeah, so breath work is amazing. I feel like it's also one of the ones that a lot of clients are skeptical with. They're always like, oh, you just want me to take a deep breath? And it's like, absolutely, I do. But sometimes we find, it's really hard for some people to understand, what does that deep breath mean to me? What is that really going to do? So explaining that we really want to slow things down. We want to slow the body down. Again, we want to help the body relax, and breath work is an avenue to do that. So sometimes teaching them different sequences of breathing can be a more structured way for that little bit more skeptical client who's like, I take deep breaths all the time. That could be working with teens too. That's popping up into my head a little bit. But 4-7-8 breathing. So breathe in for 4, try to hold the breath for 4, and then slowly release the breath for 8. Hold the breath for 7, release the breath for 8. Then there's also square breathing, which they can even do with their finger, which is a nice way to kind of keep pace and keep rhythm. So they breathe in, they breathe out, they breathe in, they breathe out, right? And they can create their own rhythm with that, which can be really soothing for clients. The 4-4-4 breathing is like the square breathing, but a little bit more structured, right? They want to breathe in for 4, hold for 4, breathe out for 4, and hold for 4 if they can. I tell them don't hold it if you can't, but try to hold it for 4. For the more visual clients, we want to do blowing out the candle, right? You can have them visualizing a birthday cake or even just a candle in their house. They can actually utilize a candle if they want and blow it out, and then just keeping that rhythm. And then of course, belly breathing. So this can be nice to do by either laying down or, sitting back in a chair. You can put your hands on your diaphragm or on your belly and taking really slow, deep breaths and actually feeling that breath go in and out, right, with our hands and getting a little bit of that movement in. So movement and nature, this can be a wonderful way for people to get some movement through their body. It can be a good way to connect with nature. The sun in itself can create huge shifts. I mean, being in southern Alberta, we just went through winter, we have the sunshine now, and we're like, we feel like new people because the sun is shining.
Everybody gets better.
Yeah. Right. So really encouraging them to try simple movements, right? I tell people, you don't have to run a marathon. You don't have to even run if that's not something that brings you joy or you find relaxing, but it's finding something that works with you. So if you can just sit outside, right, on your front step in your backyard, at a park, whatever that looks like. If you go for a walk, go walk around the block, right? Finding green spaces that you feel like you connect with. Of course, exercise, if that's something that they enjoy and find, and yoga, stretching, right? All of that can be done with movement and with nature. And one thing that we want to encourage, though, is we don't want it to be what we call prescriptive self-care, right? That's what exercise can often turn into for people. If they don't enjoy exercise, we don't want them to make themselves go exercise, because then it's another chore that they have to do, right? So it's really exploring, what options for movement feel realistic for them and within our means. What are they able to do, right? A mom who's had a C-section maybe isn't able to do the same movement that she previously enjoyed. So how can we work around that in the time being?
Okay, and this is one of our favorite strategies is mama mantras. So these are phrases, mantras moms can keep in their back pocket when they feel, but I'm not enough, when that negative self-talk is coming up. So it's going through them, and it's like, what fits for your client? Maybe not all of them do, but what ones it's like, oh, that really works for me. So for myself, it's all moms struggle at times, right? We all struggle. No moms out there say that, what, I do it all, I do it perfectly, and I've never had a struggle. I've never met a client like that. And I would say they're not in touch with reality if that's what they'd say, but it's what works for your client. And sometimes it's giving themselves permission, because some people have difficulty taking that break or taking that moment for themselves when they see dishes in the sink. So I give myself permission to take a moment, to take a break, to sit and have a coffee, right? So another one that lots of moms like, a bad moment does not make me a bad mom, right? We all have not great moments, but it doesn't mean that we're not good moms. Okay, so this is one of our faves that we love. Okay, so affirmations for postpartum anxiety. Again, this is a nice visual that you can utilize, print it off, laminate it, give it to your client, go through some of them, right? My baby's safe, my feelings are valid, I can find my calm, I have strength within me. Just things that they can bring up that will help give them that sense of safety within themselves and their body. Okay, so supportive statements that moms need to hear, probably way more often. So your struggle's valid. Sleep struggles, sleep deprivation, that is hard. All births are real births. And just, what? Support is best, because you're not breastfeeding, or because you chose this, does not mean that you're less than. Okay, and someone else's trauma does not make yours any less important, right? And you're worthy of support. That's another favorite that lots of moms just kind of tell themselves when they're feeling anxious, not enough. Okay, so how do we regulate that dysregulated nervous system? So cold water is key to activate that parasympathetic nervous system, to just brings some of that calm. So even having cold cloth, ice, going to the sink, splashing that cold water on their face. Cold water is a great strategy that people have pretty readily available too. Mindful 5. So again, another great grounding strategy. So when they're feeling caught up in that vicious cycle of anxiety, of, low mood, low distressing thoughts, it's okay, what are 5 things I can see, 4 things I can touch, 3 things I can hear, 2 things I can smell, and a positive affirmation. And then tapping, this is what we utilize from our EMDR training is, just right, left. Some of that bilateral stimulation can help calm the nervous system when our client is feeling dysregulated.
So another way this can be nice for you to kind of utilize, so kind of trying to summon these questions, right, and these themes. So, a beliefs check: am I worthless? Am I unsafe? Am I overwhelmed? Right? These are questions that you can explore with your client and keep these kind of themes in the back of your head, right? How is the client feeling about themselves? Are they feeling unsafe about the situation, about the experience they had, or in the environment that they're in? Are they overwhelmed, right? We're going back to that sensory system overload, that mental space, that default parenting, right? How is their visual space, right? Like if they just had a baby and they haven't been able to clean up and the clutter or their room around them is feeling not to the standard that they normally like, is that contributing to how they're feeling overwhelmed? So again, am I worthless? Am I unsafe? Am I overwhelmed? So these are, again, those themes that you can use to talk with your clients. Basic needs check. So I actually will teach these questions to my clients specifically. And it's, am I hungry? Am I sleepy? Am I clean? Right? So again, thinking back to the basic needs, have they eaten? Have they had something to drink that day? Are they sleepy? So are they responding from a place of fatigue? And are they clean? So is there something that they can do just to kind of help their bodies feel better? Again, we want to keep these simple. We want to keep these short. We want to keep them realistic, right? So as kind of basic, again, as they seem, always share with my clients, we really want to start at the basic level, because if you don't have that and you're not able to do these things that you feel are simple, are you able to do the other things that maybe take more time and more energy, right? And sometimes these are really helpful. It's a really helpful place to start with clients who are struggling with finding strategies that work, right? Again, coming in and saying, nothing works. I feel like nothing's helping. I've tried everything. It's like, okay, let's go back to the basics, right? And what do they feel like they can incorporate? And also the nice thing is these can be done in a really short period of time, right? These don't have to be an hour. They don't have to be 2 hours, right? It can take a couple minutes while baby's resting. It can, different things like that. So it's really important to kind of think about them that way. All right, so a deeper needs check. So this can be another way to explore some themes with your clients. So how is my space? What are my emotions? And what are my thoughts? So this can be a nice way to guide, right? We all have those clients who are a little bit more cognitive, a little bit more in their heads. We have lots of clients who are definitely in their bodies and in their emotions. So it can be a nice guide and like, okay, are there some strategies that we could start with that might be most effective for you and move into other areas that we can challenge you a little bit more, or where are we at here, right? And so asking them how their space feels to them. Does it feel comfortable? Do they feel like they have the opportunity to have it as clean as maybe they would like to, or organized, which is a big one. I know I watched those videos of like all the organization pieces and everyone's like, how does your house look like that? Anyways, but that can be a source of stress for clients, right? They're like, my house doesn't look like that, or I feel like everything's everywhere and I just feel chaotic because my space is chaotic. So asking a question like that. And then of course, where are your emotions at? What's your emotional response to things? Does it feel like you're responding how you feel you normally would? Or does it feel different? Does it feel, again, that like kind of out of control? Do you feel really dysregulated? And then of course, what are your thoughts focused on? Going back to those intrusive thoughts and cognitive distortions. So it's really giving you an opportunity to break that down. And again, this is kind of a nice way to organize it because it can keep things a little bit simple in such big themes, it can give you a starting point. So this is one thing that I utilize for my clients a lot, because I think sometimes there's a bit of an expectation on how fast change should happen. Maybe that's a nice way to say it, right? They're struggling and they want to see change quickly often, right? And it doesn't often happen that way. And so this is a nice visual to kind of talk to them about how change happens and how these strategies can create that foundation, right? And again, we want them to start simple. We don't want to get so big picture that it feels overwhelming or they set unrealistic goals for themselves. I know a big one, for example, with exercise is I'll have clients come in and be like, I'm going to exercise 5 days a week like I used to. And it's like, that's a wonderful goal, but maybe we need to like bring it back in a little bit and set it to maybe going for a walk a couple of times a week or going once a week. So we could try to set them up for success that way. So they're not feeling too overwhelmed and that they're not going to be successful with these goals that they're setting. Practice. So we encourage them to keep practicing these needs, keep practicing the basics so that they can, again, we can build on these building blocks and also help them create that distress tolerance and create that proactive strategies. So when things do get hard, they're able to naturally rely on these strategies and go back to them. And then of course, be realistic with change. Talk to them about their expectations of, you know, how fast they think it should happen or how quickly they think change occurs. And, you know, also sneaking in the conversation a little bit about motivation. Where are they at and how do they want to create this change for them? So this can be a really kind of nice theme to check in on how to set some of the foundation up.
Okay, mindfulness. That's a huge one that we try to incorporate with all of our clients. So really it's taking away from living in the past and the future and just being aware. And it has shown that people are less reactive with the use of mindfulness. And what happens when that reactive brain takes over? Those big emotions arise, and that's where we see some of that rage, some of those big explosive emotions can come up, and they do shut off that prefrontal cortex, the thinking brain. So we want to incorporate mindfulness whenever possible. So that's taking a mindful walk. We have several different strategies in the book where how can we, play with our kids for 5 minutes and be mindful? How can we put on an app and do a quick visualization? I want to start with those building blocks again. Start small and build up from there. Okay, and self-compassion, which is so critical in managing those expectations. When we don't have this for ourselves, we don't feel worthy. Our self-doubt will increase a heck of a lot. And self-compassion isn't just like, oh, that's a nice thing that would be nice to have. It's something that is so fundamental to being regulated, to being present, to having compassion and empathy.
Okay. So this is one of our favorite self-compassion exercises. It's adapted from Dr. Kristen Neff. So if you haven't looked at her website, I strongly encourage you to. It has some amazing meditations, self-compassion exercises, and she's kind of the guru of self-compassion, so to speak. And so what you'd have your client do is take calming deep breaths, kind of place their hands over their chest, or if you want to have them do the belly breaths, you can do that as well. And we really want them to state the following. So an affirmation that acknowledges their experience, an affirmation that is related to commonality, that, everyone has a struggle and everyone has a moment that they're not doing well in. And then of course, that kindness or strength, right? Really validating that your experience, your emotions, your person is valid just as they are in that moment. And so this can be a really great teaching exercise. So this is another reminder we give our clients too. Again, start simple, keep them practicing, and be honest with where they're feeling. So that can tie really nicely into that self-compassion piece, because we want them to start building again that foundation. We hear all the time, we didn't know that we were supposed to be self-compassionate, or it's not something you're taught in school. How do you do this, right? So just as the basic needs check, we really want to start small and build up that skill in doing that. So of course, there are times when a physician or higher level care is needed. Typically in our practices, we do want to have that physician working concurrently when we're with our client, just as a resource. However, these are situations where you definitely want that referral and are wanting to connect them with their physician, with the emergency room, right, when higher levels of care are needed. So suicidal ideation, intentions to act on self-harm thoughts, homicidal ideation, postpartum psychosis. So a warning sign of postpartum psychosis, which again, we can't dive into every topic, but one thing that you're wanting to look for with the postpartum psychosis, if your client is experiencing intrusive thoughts and those thoughts don't feel disturbing to them, they don't think that they feel discomfort, they just feel like an average or relatively normal thought to them, that's a warning sign that this is a medical emergency. So that is when you're wanting to explore that with your client, or connect them with their physician and explore what supports they have immediately. Exploration of medication options. So of course, there's always medication that the client can take. This would be a decision of their family care provider or their pharmacist, whoever they're connected with. And so you'd want to refer them to who they would be connected with and who they would be able to get that medication from, because often clients do want to explore medication or want to know what that information looks like and what that's about. And that's the best resource for them in terms of being able to connect and explore that option. Specifically for us as psychologists, medication is out of our scope of practice. So that's why we would just inquire if they are taking any medications, yes or no. Is that an option that they're wanting to explore? And then connecting with them to those referral sources. If there's significant impairment in day-to-day function, as proactive care, if the client is desiring those options, right? If they come to you and they're like, I really think I need a psychiatrist, or I want to know what inpatient programs look like, that's another sign that it's time to connect them with those services. Do we this one?
Do we have time to do this one?
We can go through it quickly.
Okay.
So Simone is another case conceptualization that we'll go through. We just want to be mindful of time and mindful of questions. So Simone booked an appointment on her own without a referral. She reported that she was struggling with burnout. So she felt like she was drowning, was the language that she utilized, and didn't know what to do anymore. So she reported she was struggling after she had her third child, and her third child was diagnosed with colic. So a very significant temperament in terms of lots of crying, lots of discomfort, lots of lack of sleep, and she felt like a lack of support at that time. So Simone had a history of anxiety and depression, which she had been diagnosed formally by a doctor, and she felt that it was managed when she was on medication. She went off of it because she did feel like it was so managed, and at that time she had started to consider starting medication again. So her presentation, by her description, was burnout. Her precipitant was having difficulties with her baby who was struggling with colic, and she felt very triggered by crying and felt very overwhelmed. So her pattern, so she would use work as an outlet. That was her time away from the kids, but she had recently started a new position and she felt like she wasn't at ease anymore. So it felt like she was trying to put all this energy into learning her new job and then all this energy in at home. She did have a baseline of cognitive distortions. However, she felt like those were managed before the colic diagnosis for her baby. From a cultural perspective, she was from a multiracial family, and her social, she did have limited family support outside of her partner. She was estranged from her family because of addictions, and her partner wasn't supportive of counseling at that time. So she felt he was good in terms of day-to-day tasks, but from an emotional perspective, felt a lack of support as well. She had, again, biological, she was diagnosed with depression and anxiety, and from a psychological perspective, she felt easily triggered and overwhelmed and shut down when her children were crying or needing her, or even having tantrums like the older child. So her perpetuants were managing family dynamics with little to no support. and she felt like her partner could be helpful again, but at most of the time felt like a default parent. So her protective factors and strengths were she had awareness that she was struggling and she was prioritizing counseling, and she was also motivated for change. So the plan for Simone was to work on boundary setting and exploring ways to create a bigger support network and to offset some of that parental workload. So some relationship work as well, right? So there was difficulties in being able to ask for help, being able to feel like her partner was on the same page as her, and finding ways to connect with other moms in a different way was important and a priority for her. So her prognosis was good, given that the client had strengths and motivations. So it was likely, if prioritizing support and needs can be expanded with the significant barriers, that there would be improvement after therapy. So a big referral option for Simone was couples counseling, because that's not something that we typically do in our private practices. And so that would be something we would want to refer out for. It would also be good to find, again, those resources in her community that she could reach out to and make connections with. And again, we'd want to follow that treatment plan and trying to prioritize different experiences. There was also some significant past trauma work that needed to be done, but it was trying to find where we could start and work through at the time and breaking it into smaller pieces, because obviously with the familial history and being estranged from her family is going to bring up a lot as well. So it was finding a balance for those different struggles.
Okay, so just to sum up the coping strategies, right? So we always want to make sure the health care provider, so their OBGYN, family doc, are aware. So we want to have a therapist that is trained in the perinatal period, or we know that's not always realistic depending on where people are located. An experienced therapist. Medication can be an avenue, of course. Finding those coping strategies that work and building on top of them, starting small. And, if there are themes or different strategies in your theoretical orientation that are a good fit for them, absolutely. And we always want to utilize those body-based strategies, mindfulness, grounding, to help kind of calm the nervous system, help them find that safety within their body, and then becoming aware of supports and resources within your specific community.
Just enough time.
Okay.
All right, so we're going to go through some of the questions. Unfortunately, we probably won't have time for all of them, but we will get through as many as we can. If you have some specific ones, we'll just quickly go through.
And then you can also connect with us on Instagram, email, our website. We do have a number of different workshops that are tailored for clients specifically. So we have one on postpartum anxiety, burnout, rage, and depression. We also have different ones that are more specific for parenting. So working with, screen time, having a highly sensitive child. We have a number of different workshops available on our website for clients or practitioners.
Yeah, so with the PSAS, I should have been a little bit more clear on that. So we're just starting at the top of the question, sorry. There is research that shows it's an effective screening tool, but there's limited access. So you can use the PASS, which is the Perinatal Anxiety Screening Scale. However, if you don't have access or are unable to use screening tools, just having the conversations that we've been talking about are an effective way to find out what's going on. And then, of course, you can always refer to family doctors, or if there's specific people that do assessments in your community, to answer some of those questions if you are wanting that formal assessment. Sorry. Do we use infant mental health providers as supports also?
Yes, definitely we would. In our area, we don't necessarily have a lot of infant mental health providers, but then we would also work alongside. I'm a child psychologist as well. We both work with kids, training in play therapy and attachment, but definitely we would also utilize an infant mental health provider as well.
Okay. For tests for postpartum psychosis, unfortunately, there is limited assessments in general, and psychosis isn't necessarily one of them. That's why we talk about like the intrusive thoughts and how they're feeling about the intrusive thoughts. So if you do have that concern, or even if you're like, I don't know if this could be potentially going on, always refer to the family doctor. Or if they do share with you that those intrusive thoughts don't feel disturbing, get them to an ER for an assessment on that, because if it is postpartum psychosis, it is considered a medical emergency.
And the strategies, they are primarily based on CBT, because of that is what the majority of practitioners that we find are trained in. And then personally, we utilize EMDR. I also utilize sensory motor within our own practices. But for the purpose of this presentation, CBT was a primary model that we utilized for the strategies and interventions.
Do you find that postpartum is often diagnosed as adjustment disorder? You know what, adjustment disorder is interesting. You will often find that not necessarily that people meet the criteria, but I wonder about it, especially with birth trauma. And NICU or medical journeys, because there is that borderline PTSD that can come up, and adjustment disorder is similar to PTSD, but often not as long lasting. So that's when we kind of look at that adjustment disorder. We did discuss some medications. Yeah, medications for sure. It's not within our scope of practice, but we always talk to our clients if that's something that they're wanting to explore, or if they're taking, and then refer to the appropriate source. Notice dissociation. Yeah, absolutely. Dissociation can occur, like in terms of, feeling like not remembering, feeling body disconnect, right? All of those things in stressful events. You hear it a lot, actually, that disassociation in birth, birth trauma, as a coping strategy.
Yeah, so thriving, yeah, I mean, these are just words that we utilize. You can change it to whatever you want. In our Instagram polls, we usually have doing good, meh is a common one, and struggling, right? So you can change it to whatever words you want to use. Yeah, I mean, there's a lot of toxic things on social media, but yeah, change the word for whatever suits you. Yeah. Do you see that the age of the mother during the perinatal period influences the risk?
Not necessarily. I think it's more those external factors than the actual age of the mother. Sometimes you'll find like mothers who are labeled as high risk due to maternal age have the different struggles in terms of dealing with that, like what that means if they don't identify or feel like they connect with like being, what is the term? Gestational, no.
Oh, I forget.
I forget. Oh my gosh. But when they're labeled as being an older mother.
Oh, geriatric
Pregnancy. Thank you. Sometimes like having that term constantly thrown at them can impact how they feel about themselves and how they feel about their pregnancy. So some of those factors can be influencing, but not necessarily just like their numerical age.
Yeah, one it will be a smaller influencing factor, I would think, and just depending on all of the other external factors going on.
For sure. I will preface that with, though, teen mothers would be a little bit different. So we're talking more mothers who are out of the teenage years.
Yeah. Would you just make me down to that one? Okay. So yeah, clients developing anger and rage towards their partners during the perinatal period. how to support, understand shifts in relational needs when most of the anger appears to stem from the relationship or is attributed to the partner. So that is one where it goes back to that default parenting, the mental load in parenting, and how can we work with the client to shift some of that load so they can get their needs met, right? Where can we start? And we're going to start small, but how can we open up that conversation to, you know what, you are frustrated with your partner because all the kids are crawling on you and you're doing bedtime and things like that. How do we make it more equal? And how do we make perhaps mom more comfortable with other parent taking over some of those roles?
What about the clients that I just say, I just can't? Yeah, those are tough, right? It's hard because, you know, they come in feeling like I've tried everything, and often they feel like counseling is or therapy is kind of a last resort, right? They're like, here, because I'm like, I don't know what else to do. And so I would look at a few different things in terms of what their level of change is at, what their expectations are, you know, what do they feel like is what they've tried? Like, I would really want to understand that a little bit more. And if they feel like they just can't, like, what do they feel like their barriers are? Like, what is preventing them from being able to do what they're saying they would
taking some of those small steps. And it is really getting realistic, right? Because some moms, they just simply don't have the support. So it's like 5 minutes. When you have 5 minutes, what can you do? And it's kind of going back to lowering the bar. It's like, okay, if you need to put on a show for your kid for an hour, that's, you know what, if that's what you need to do, that's what you need to do, right? So it's exploring some of those expectations and values too.
Do we meet with dads? Absolutely. I love working with dads. It seems like it's still more primarily moms that will come to therapy for postpartum or in the perinatal period. At times there's been that couples that have struggled with infertility, or dad wants to come in to learn how to support mom better. But dads are actually included in our postpartum coping plan as part of the strategies and part of the awareness of what that can look like for dads and what that can look like for moms, and, you know, how to have some of those foundationary conversations as early as possible. Because we all know sometimes we can only prepare as best as we can when we haven't gone through it or things like that. So, but yeah, absolutely. We both work with dads. Definitely. What are some online resources we suggest? We actually, in our book, we have one at every single chapter on the different topics. We can give you some examples. Postpartum International is a great one.
It's a great catch-all.
Catch-all for sure, as kind of a foundation place to start.
But in our book, after each chapter, so say relationships, we give some of our favorite practitioners, some of our favorite Instagram accounts that deal with that specific area. And I mean, obviously us, but there are really, really good accounts out there that talk about, you know, what the postpartum period and normalize some of that for moms. The Diary of an Honest Mom is a great influencer to follow that really talks about just the realness. And in a day where we're just kind of inundated with the perfect looking influencers, and that has, you know, the perfect house and all the things going on, moms need more people that they can look at, and it's like, oh, she looks like me, her house looks like my house, her life kind of looks kind of like my life. So
in terms of brain changes, yeah, it gets a little neuroscience-y, but research is finding that there's some gray matter changes. So there's a lot of amazing studies out there that I encourage you to look up. Google Scholar, if you don't have access to like a research like a university publishing scholar, you can use Google Scholar, and there's a lot of great ones that will talk about the gray matter changes that occur, but we're really looking at things that will shift and create change in terms of bonding. And then of course that evolutionary perspective that Caitlin was changing to look for danger, and that's again that heightened anxiety. So yeah, that would be where I would start with some of that information. And in terms of the healthy ways to express anger, so lots of the coping strategies that we had kind of went over, right? Movement is a great one for anger, I find. Finding ways to like get that the energy, right, that kind of comes with anger sometimes out of the body. Art can be a great way to express anger. Finding ways to connect and support, finding somebody who you feel like you can share that understands the anger. So that's more of a verbal processor. That can be a great way to do that. Some clients who really love exercise find movement, boxing, right? Anything that's kind of more intense, has a higher intensity in exercise can be really helpful. It's really exploring what kind of works for the client too, right? There's some who are more expressive through music, right? So maybe they blast some like screamo music and that just like helps
Sing
them
in the car and cry.
and gets it out, right? Or maybe somebody needs to do some more like meditative grounding practices. So lots of the strategies we have talked about can be adapted that way.
And it also goes back to also setting boundaries, right? Sometimes that anger can let you know, it's like, okay, I need to set some boundaries with somebody, maybe my partner, maybe my mother-in-law. And we also encourage exploration of that. Okay, well, we are at time. Thank you guys so much. This has been amazing. Thank you guys for attending. I apologize for the
slides. We will
the
get
spelling.
the
We'll get the correct slides. I added a few visuals in and I added it to the wrong one. So thank you guys so much. Yes, thank you. And of course, visit us on Instagram, follow us. If you have a question, email us, visit our website. We're here for you guys, and we're just really excited to present more information, more things that can help the practitioners that are working with moms in today's day and age. Okay, thank you guys so much.